who have joined from various parts of India and abroad. Welcome to this live webinar. I'm Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speakers, all discussants and participants. Today we have two talks and one panel discussion. First talk will be delivered by Dr. Neeraj Arora from Ahmedabad. He will be speaking on genomics of DLBCL, followed by a talk from Professor Zurk from Poland. He will be delivering a talk on novel agents in CLL. And subsequent panel discussion will be moderated by none other than Dr. M.B. Agarwal, sir. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this continuous medical education series under the aegis of Mumbai Hematology Group, Dr. M.B. Agarwal, sir. Sir is Professor and Head Department of Hematology, Bombay Hospital, Institute of Medical Sciences, Mumbai. He is also associated with other esteemed institutes like PD Hinduja Hospital, Leelavati Hospital, Fortis Hospital, Breach Candy Hospital in Mumbai. He is the president of Mumbai Hematology Group as well. I request Dr. M.B. Agarwal to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit Madan, for those kind words. Good evening to one and all. Today, we have two talks. Dr. Neeraj Arora from Ahmedabad would deliver the first one. And then we have Dr. Zurzik from Poland, who will be giving the second talk. This will be followed by the panel discussion on Zanubrutinib in chronic lymphocytic leukemia, an update from EHA 2026, which was just held 2 weeks ago. I'll be moderating this, and we have very important faculty as the panelist. Dr. Anant Gokarn from Mumbai, Dr. Arijit Vishnu from Kolkata, Dr. Asif Iqbal from Guwahati, Dr. Kundan Mishra from Lucknow, Dr. Monisha from Kochi, Dr. Revant Bodu from Bengaluru, Dr. S.P. Verma from Lucknow, Dr. Tribik Ram Panda from Bhubaneswar, and Dr. Upendra Sharma from Jaipur. So today will be a little tiring day for you because 3 hours, 3 activities, but I'm sure there will be a lot of learning. We begin with our first speaker, Dr. Neeraj Arora, who will be speaking on genomics of DLBCL. Are we ready? The second part of it, are we ready, is the most important one. All this webinar today is brought to you by Mumbai Hematology Group. It is supported by Zydus and Glenmark, managed by Perfect Square. I thank the team from Zydus and Glenmark, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speakers, Dr. Neeraj Arora and Dr. Worzik from Poland. All our discussants were themselves eminent hematologists, medical oncologists, and even hematopathologists. The new participants for sparing your Thursday evening. Coming Thursday, 9th July, 6:30 p.m., we have Dr. Fahima Hassan, Assistant Professor, Department of Hematology from United Institute of Medical Sciences, Prayagraj, speaking to us on novel therapies in myeloma and sequencing strategies. And then our own Dr. Deepanjan Haldar, who was from Mumbai but now settled in UK, will be speaking to us on ETP, acute lymphoblastic leukemia. A few words about Dr. Neeraj Arora. He's MD Pathology, PDF Hematopathology, PDF Molecular Hematology, Director Molecular Biology, Unipath Specialty Lab, Ahmedabad. He is a molecular pathologist par excellence. He gave his services to Tata Medical Center, Kolkata for 7 years. Before that, he had worked in the Department of Hematology, CMC Vellore. He is instrumental in setting up affordable diagnostic molecular techniques for hematological and solid tumors using the techniques like NGS and digital PCR. And today, he will be speaking to us on genomics of DLBCL. Are we ready? So I stop here and give the platform to him.
I hope my slides are visible.
Yes.
So at the outset, thank you so much, sir, for this opportunity to come here again and share some of the knowledge with respect to the topic of DLBCL, which is very close to my heart, and we have been working in this area for some time now. So the topic that I'm going to share is genomics of DLBCL, and are we ready? So what I have done is I'll take you through the things that are happening in this field, and maybe in the end, then we can have a discussion in terms of what we are doing and where we are in this aspect. So we are talking of DLBCL, and it is as an entity. It is the commonest lymphoma that we see, and this is through some of the studies that already been done. So we are dealing, whatever we are talking is one of the commonest lymphoma that we see. So it is almost around 50% of the lymphomas that belong to this category of diffuse large B-cell lymphoma. And traditionally, we have known as a pathologist, we have, when we see the slides, we see different aspects of, all these are diffuse large B-cell lymphomas with different forms that we see. These are 4 different types of morphology that we see. And another cases or another morphological features showing diffuse large B-cell lymphoma. So this is an immunoblastic, and in the E you have an immunoblastic form with giant cells, and there could be different variants like plasmablastic variant, immunoblastic morphological variant, all being categorized into one category of diffuse large B-cell lymphoma. So the point that I'm trying to make here is that it is a very heterogeneous entity that we know in terms of pathology as well. And there are different morphological subtypes, and many a times over the years, it used to be a wastebasket term. So something which is not fitting into one category used to be put under the category of diffuse large B-cell lymphoma. And we know that it is very, very heterogeneous, though in terms of a treatment perspective, and in terms of whenever I show that this is almost 50% of the lymphomas. So it is not a single entity. Actually, it is quite heterogeneous. And based on morphology, immunophenotype, we have been trying to categorize them into different subgroups based on IHC. But now over the years, over the last, I think 15, 20 years, a lot of work has been going on to look into more into these categories. And these are some of the things in terms of genomics that have happened. There has been genomic profiling. Then we have had the double hit lymphomas been described. Then there has been a transcriptomic identification of the microenvironmental signatures. And now there has been whole exome, whole genome data contributing to mutational profiling, microenvironment signatures being described, and integration. So a lot of things have happened in the last 15, 20 years, and I'll try to touch upon some of the things that we have been doing and available in our settings. So as we know, with respect to the B-cell lymphomas, understanding the normal morphology of normal maturation pattern helps a lot in our understanding of the B-cell malignancy. And this is a very simplistic view to help understand as we go along that where we come from, or what we are doing in terms of genomics, because genomics helps understand these DLBCLs in a better way. So in simplistic term, as the B cells are exposed to antigens, they go through the germinal center in a lymph node. So there is a proliferation and somatic hypermutation happening, and this B cell matures through dark zone going through the light zone. And in the light zone, you have these B cells, which are now maturing from the immunoblast stage, along with the follicular dendritic cells and T cells within the light zone, there is a selection and class switch recombination happening, and these B cells now mature into memory B cells or plasma cells or the apoptosis. So this is a normal B cell development in a very simplistic way, and our understanding of this DLBCLs now more or less mimics whatever is happening in this B cells. What is happening to these B cells? So as these naive B cells go through different phases, germinal center to the plasma cells, there are a lot of transcription factors which have been implicated at the entry and at the exit. And these are some of the transcription factors, and we keep hearing them not only in this as a transcription factors or genes or mutations, also in terms of IHC, use of IHC of this transcription factors. So some of these transcription factors include PAX5, BCL6, MEF2B, MYC, NF-kappa. They are primarily engaged in the germinal center initiation, or where these B cells go to the dark zone, and subsequently there are transcription factors like IRF4, PRDM1 or XBP1, which are implicated in the maturation or as these B cells exit the germinal center. So we've been hearing some of them, and this is the interplay of the transcription factors leading to the switch off or switch on of the BCL6 gene, leading to whether it will be showing the germinal center phenotype or non-germinal center or post-germinal center phenotype. So this is dependent upon these transcription factors and these reactions which are there going on in these germinal centers. Now, our understanding of these lymphomas is mainly based on this maturation of these B cells as it grows through the naive phase, germinal center, and post-germinal centers, because we now understand that most of the lymphomas have their cell of origin, and they, from each of different cells, it could be a centrocyte, centroblast, immunoblast, marginal B zone, follicular T helper cell, Tregs, plasma cell, plasma blasts. So each of these cells give rise to a lymphoma or a malignancy which is attributed to that particular cell, which is at different stages of maturation. So our understanding of the lymphoma has mostly been based on this maturation of this B cells. And with respect to the diffuse large B cell lymphoma that we are talking, so now this diffuse large B cell lymphoma is now, in terms of gene expression profiling, we now know that it is not a single disease. It has been characterized through the process of gene expression profiling. This was through a landmark paper in 2000, where they described that these DLBCLs actually are not single lymphoma. There are 3 subgroups within that. This is a germinal center B cell like, then there is an activated B cell like, and type 3 or unclassified like. And this is with, as it very similar to what is shown in the germinal center reactions that I just described. So very similar to that, you have the cell of origin concept, where each of these DLBCLs arise from a particular type of phenotype. So there is a germinal center B cell like mimicking the germinal centers, then activated B cell like mimicking the post germinal center phenotype. And this description had important because of the prognostic relevance attached in this study, where they showed that the DLBCLs with the germinal center B cell like did well, as opposed to those with the activated B cell like. So characterization of the DLBCL using an RNA based or RNA expression based profiler allowed us to be able to characterize these DLBCLs into 2 or 3 subtypes: GCB, ABC, and unclassified subtype, which had a prognostic relevance. And now going further, there was an assay developed. This was an assay. So this RNA is to be considered as a gold standard in this. And subsequently, a nanostring based 20 gene expression was developed on an FFP, because working on an RNA was difficult from the FFP. And this nanostring platform or the assay allowed us a better reproducibility and more accuracy in terms of characterization of this DLBCL into these two entities. So this lympho 2CX assay was described, and this assay was subsequently correlated with the gold standard RNA and show a very high degree of concordance. So using this assay, we were able to reproduce with very high degree of accuracy the GCB and ABC subtypes. But the challenge remained in implementation of this, or the availability of the lympho 2CX type of assay in the clinics. And there the attempts were made using IHC algorithms, some of the algorithms I'll describe later. So there was a high degree of correlation of this assay with various IHC and with the data available. And also it showed that using this this nanostring assay, the reproducibility in terms of overall survival and PFS was very, very similar. So using this assay as compared to the gold standard, whatever was described using a gold standard, it was very reproducible. And that is how this assay kind of was described. Now, to be able, there were challenges in implementing this assay into the clinic, and then many other techniques were described. And one of the popular techniques that was adopted and still being practiced is the immunohistochemistry, which is now sort of the most commonly used method of characterization, as opposed to the gold standard RNA assay or the nanostring based assay. There were various algorithms which were described, various IHC markers, various cutoffs, and this is some of the list of the various algorithms were tried, which started with Hans, Niemann. There are different algorithms which were tried for this characterization, but two of the popular algorithms being the Hans algorithm, which is most used in practice. This is a 3-marker based IHC marker assay, which includes CD10, BCL6, and MUM1, with 30% as the cutoff to be able to characterize this DLBCLs into GCB and non-GCB. With using this algorithm, there was a accuracy rate of around 80% of the lymphomas. So with the accuracy of 80%, you are able to correlate with the gold standard, the RNA. There were cases which were wrongly characterized, and that is the problem. And therefore, new algorithms were characterized. And the another algorithm, which is 5-marker algorithm, it is the COI algorithm. This raises the accuracy level to around 90%. So gives some advantages. But the most common the IHC approach is the Hans algorithm. There have been some attempts made by using different techniques as well, and this is one technique described from India. So there have been a lot of publications from Indian settings as well, where using different approaches, Hans or COI algorithm, we can characterize this DLBCLs into GCB and non-GCB as for prognostic role. This is one technique, that is RT-MLPA being used. So this is a slightly cheaper assay, and attempted to be able to characterize this DLBCLs into various subtypes. Now, why this attempt was being made? Because the Hans is not 100%, and the nanostring or the gold standard are not available. There are challenges in implementing those assays, and therefore different techniques are to be able to characterize this DLBCLs into 2 subgroups, which have been described as having prognostic role. Now, in the current WHO, which is 2022 classification, this character and And the applicability of this GCB, non-GCB outside the clinical settings has been slightly limited. So though we continue in terms of prognostic characterization of GCB, non-GCB, and the current WHO also prescribes, but I mean, it is not beyond that it has gone ahead. There is a trial, which is Polarix trial, which is done in 2022, where this GCB, non-GCB characterization has had an impact in terms of frontline treatment options, where as opposed to CHOP or R-CHOP, the addition of POLA had a benefit in the ABC subtype. So, so there and high IPI DLBCL cases. So in those settings, this cell of origin has had an impact, but more in the prognostic descriptions. So the other area in terms of in terms of the genomics is the role of MYC BCL to BCL6, and there we have had the description of double hit lymphomas, and there the backbone marker or backbone biomarker that we use is the c-MYC rearrangement by FISH. So this forms the gold standard, and subsequently FISH by BCL2, BCL6 helps us characterize whether this is a double hit lymphoma or not. If you look at the all DLBCLs, so if I have this is one study which tried to characterize more than 1,000 DLBCLs, and there just using c-MYC. So I think the c-MYC positivity in all types of DLBCLs varied around from 10 to 12%. So this is 12%, showing that in all DLBCLs around 12% will show c-MYC positivity, and further around 5% had MYC alone. The MYC and BCL2, which is primarily seen in GCB subtypes, around 5%. And then the very less number of cases had MYC BCL2, BCL6, and the triple hit is what we call this. This again is in the GCB setting. So now this double hit lymphoma, which we used to call anything MYC or BCL2 or MYC or BCL6. Now we understand that the MYC BCL2 is what defines the double hit lymphomas, and MYC BCL6 are they have a slightly different gene expression, and in terms of prognosis, the MYC BCL2 do bad as opposed to the MYC BCL6, and that thing has been characterized further and has been implemented into the current WHO settings, where now in terms of if you look at the diffuse large B-cell lymphoma, so anything MYC rearranged along with BCL2 rearranged is what we will call it as these DLBCL's high-grade B-cell lymphoma, MYC and BCL2 rearranged. So BCL6 rearrangement, there or not there, does not matter. So and a distinct name has been introduced to be able to reflect upon the importance of MYC and BCL2 positivity. So anything other than that, BCL6, it may not come under the typical description of double hit lymphomas, because the prognostic relevant of the MYC BCL6 is different from the MYC BCL2 lymphomas. So this is to highlight that aspect, and this is current WHO classification also recognizes that double hit lymphomas is called as DLBCLs, high-grade lymphomas with MYC and BCL2 rearrangement. So this has been the important change in this subgroup of cases, and you can see the WHO current WHO describing the cell of origin. So this is still recommended in the WHO classification, and this classification is still traditional based on morpho, immunohistochemistry, and immunodeficiency and site. The genomics has not been fully implemented in WHO as well. Very few genomic things have been implemented, which include BCL2, BCL6, IRF11Q and IRF4. Other than that, mostly still it is based on morphology and immunohistochemistry. So with respect to double hit lymphomas, is our understanding has improved. Another area where our understanding has improved and we continue to learn is the description of dark zone signature. So the term double hit signature is now being replaced by dark zone signature because of the understanding that that this dark zone signature. So within GCB subset, you have a dark zone signature which includes cases which is positive for Burkitt. So Burkitt lymphoma can have a dark zone signature. The typical double hit lymphoma also is a part of dark zone signature, but there is a category of DLBCL, recognition of this category, that DLBCL NOS dark zone signature type, which is negative for BCL2 and BCL6, and this forms a part of the GCB subtype, and they do bad. So recognition of this entities has been an important aspect, and that is what I'm going to highlight further on the recognition of this dark zone signature. So this is a study published by David Scott in 2023 in Blood, and they share that they define this the double hit to be renamed as dark zone signature in a study of around 1149 patients in Vancouver, and they show that the dark zone positive DLBCLs, dark zone non-dark zone GCB DLBCLs and ABC are associated with a 2-year survival of 57%, 89%, and 71% respectively. So we used to know that GCB is good, but within GCB also there is something called dark zone signature positive DLBCLs which do bad, and this is worse, more poor than the ABC subtypes as well. And 60% of those dark zone tumors are negative for the BCL2, that is MHG BCL2 by FISH. So basically there is a subcategory within GCB which does bad, and the FISH of BCL2 and MHG is not able to pick up, and that is what the implications are there for that. And this is another slide showing the same thing, that now using an assay on nanostring, which they call it as DLBCL 90, they tried to characterize these lymphomas, and they found that 12% of those lymphomas have a signature which is called dark zone signature positive, and those within those 12%, this is primarily GCB subtypes, and 60% of them are negative for the FISH negative. So that has been what has been described from this study. And when they compare that with the in terms of PFS and overall survival, you can see that the ones with the dark zone signatures do worse. So as opposed to the GCB subtype. So the dark zone signature positive. So just trying to show that in the two slides that this is GCB, non-GCB, and down here that dark zone signatures do bad in terms of the PFS and the overall survival. Yeah. Again, the same thing that so the another important point is that the same thing that within dark zone signatures, both which are FISH positive and both which are FISH negative, they do bad. They are bad. And this dark zone signature, recognition of this dark zone signature, again, that this mimics the whatever I showed in the germinal center. So within germinal center, there is a dark zone and the light zone. So dark zone signature positive, which now can correlate with the Burkitt lymphoma signatures, and the FISH positive cases, and one which are FISH negative cases. And so this characterization or recognition or description has been mainly on the FFP specimens. and using an assay platform is the NanoString platform, which is not available or currently available. Neither is the earlier assay available, nor this assay is available. So now using that assay, they have been able to characterize these DLBCLs with the dark zone signature positive. And now they used to, they tried to implement this assay in different settings. So they used a cohort of people in Japanese patients, and they tried to show that this is whether this is reproducible or not. And using this signature, so they were able to reproduce the outcomes that they got in the Vancouver, showing that this is a robust biomarker regardless of the geographical setting. So they were able to reproduce this results in a separate location using the same assay, showing that this is indeed biomarker for recognition of this poor prognosis category of cases. So this was the things which is happening with respect to the double hit lymphoma cases. And third important aspect is the mutational profiling. Over the years, we have learned that there are different DLBCLs, and there are different mutations being described in GCB subtype, primarily BCL6 EZS type. Similarly, there are mutations which have been recognized in DLBCLs, which are activated B cell like mutations in NF-kappa B, CARD 11, MYD 88, CD 79B. So mutations along the pathways, primarily the NF-kappa B pathway. And then there have been attempts to be able to target pickup using targeted approaches. Like here, there is an attempt to use IHC for a specific EZI2 marker, picking up GCBs for targeted therapies in EZS2 using IHC based approach. So some of the approaches being able to see that whether we can get into the clinic. So for use of EZS2 inhibitors, an IHC based approach to see that whether we can target them in terms of therapy. So what I'm trying to share is that DLBCL in terms of mutation profiling, GCB, non-GCB, and further mutations, trying to see whether we can bring it to the clinic. So this was one attempt with respect to the EZS2 inhibitor therapy being tried. But a lot of work has gone into the genomic profiling, and now there have been few descriptions further than the GCB, non-GCB, and we have now category descriptions of EZB subtype, BN2 subtype, MCD subtype, and N1 subtype, N1 notch 1, and MCD, MYD 88 being there, then BN2, BCL6, and notch 2 mutations. So this is some of the mechanisms and some of the molecular hallmarks and some of the potential targets being described in these categories. And this is all across all type of diffuse large B-cell lymphomas being trying to characterize them. So this is not a single study being there. Last 4 or 5 years, lot of studies at different places, different institutes have taken place, and now we are in a place where we can have some sort of consensus, some sort of recognitions in terms of the description. So there is MCD, N1, A53, BN2, ST, EZB, MYC positive and negative. So different subgroups here. Then we have C1 to C5 clusters or categories being described in different studies, and so many studies, but some sort of unification and underlying some mechanism, BN2, BCL6, and NOS2 being the prominent mutations in the C1 or BN2 type of category. Then A53 typically having TP53 as the primary molecular marker, and C3 or having two subtypes, which is EZB based on the presence of EZS2, BCL2 positivity, and if it is MYC positive or MYC negative, two subcategories here. So our understanding of this has increased, and we know that there are C1 to C5 categories, and there is an overlapping among different studies, and the understanding of this mutation profiling of is there. And more or less the distribution of these subcategories in different studies are there. And moving further, we've been trying to understand the clinical implications of these mutations, and that is where our interest has been there, how we can take this to the clinic, this knowledge to the clinics. So as I mentioned, C1 corresponds to BN2, and the key mutations being Notch2, BCL6, and typically associated with ABC. And the clinical association is with marginal zone lymphomas. And this they have one of the they have been described with marginal zone, and possible targets include BTK, PIK3C, or BCL2. Similarly, C5 or MCD type of lymphomas, one of the very good prognosis subcategories, typically ABC subtypes at extranodal sites, and potential targets being the BTK inhibitors being described. So this has been a distinct recognition of these categories and potential clinical associations, like Notch1 being described in an ABC subtype of DLBCLs, and probable associations with Richter transformation of CLL, and again BTK inhibitors being one of the therapy or therapies which could be tried in this subcategory of cases. So our understanding has improved in terms of mutation profiling. We now understand the C1 to C5 categories with particular type of mutations and potential targets which can be there for this subcategory. This might sound a little complicated, but what this slide is trying to show is from the morphology aspect, then looking at this category, the genomic aspects, and trying to have somewhat unified molecular profiling. But yes, some work more to be done in this area, to be in a way where we can start practicing on this. But what has been done using this data that is available? Some of the trials have been done, and one of the trial which I could figure out is the Guidance 1 trial, where as opposed to a traditional R-CHOP, using a 20 marker algorithm, and based on this mutation profiling, picking up the treatment as opposed to the different mutation profiling. So this R-CHOP versus based on mutation MCD, like then you have addition of ibrutinib, BN2, then is the addition of ibrutinib, and N1 like lenalidomide, then is EZB, addition of another drug, then TP53 decitabine. So based on the 20 marker the mutation profiling, choosing the drugs, this trial showed the definite benefit of the R-CHOP X. So whatever addition of drugs showed an improvement with respect to the R-CHOP from 66% to 86% response rate here, and showing benefit in the overall survival and the PFS. So showing the utility of the genomic profiling and reaching to the clinic. But this was not this. So further trials are needed, and they have started another trial based on this data, showing that this is doable. So another large trial is being planned under the Guidance 2 trial. So Guidance 1 actually showed that targeted agents based on genetic subtyping could improve the R-CHOP efficacy, and inflammatory and immune depleted had a greater sensitivity to the therapy, and genetic subtype guided immunotherapy could be a promising line therapy in DLBCLs. And so based on this initial data, further larger trials are needed to be able to bring those information into the clinic. And this is one study, lymphomatch being described or being planned in US, large trial being planned in US. So another area where this genomics or is looking at is the microenvironment of DLBCL. So apart from the mutation profiling, the microenvironment has also been being described or characterized, and various studies have tried to use that. And there has been characterization of ABC hot, ABC cold, GCB hot. So apart from GCB, non-GCB, further looking at the immune subset or the microenvironment, again helping decide the treatment or the prognostic implications. That is another area which is being done. The last but not the least is the use of the plasma or cell-free DNA in DLBCL settings or in lymphoma settings, and where this plasma is looked upon another material for characterization of the diffuse large B-cell lymphomas and in other B-cell lymphomas, where it could be used for diagnosis, characterization, and post-treatment monitoring, and helping you assess whether this patient is progressing. So this is one area where again work has been done, and a lot of data is coming up in the use of ctDNA for monitoring or of diffuse large B-cell lymphomas. There have been various approaches which include the methylation approach, using the IGH gene sequencing, the mutation sequencing. So we now understand diffuse large B-cell lymphoma with respect to mutation profiling, subtyping. But yes, in terms of prognosis, it is there. But what to use and how to change my therapy based on that is where we need a lot of data. In terms of monitoring, different approaches being described, a lot of data being described. And this is one such study where they have tried to use DLBCL molecular data for characterization and using for minimal residual disease assessment. This is data of around 64 cases. And so using the plasma sample of large B-cell lymphoma at diagnosis and subsequently at monitoring, just to share with you that various mutations could be picked up here, and we could be characterized into DLBCLs, GCB, non-GCB, and we can take a help or allow you to be able to do that. And also for monitoring purpose, where I could use this information post-treatment as well. To illustrate this, one example is there where for a particular diffuse large B-cell lymphoma, at diagnosis, you have the mutations in the genes of MYD88, BCL6, NOTCH, CCND, and TNAIP3. So these are the 5 different variants which are present at variant VABs at diagnosis in the plasma of that patient, and subsequently post-treatment, this decreases to 0. Then after 6 cycles, some of the mutations show an increase. And after 7 cycles, where there is a so there is a correlation between PET, biopsy, and various markers. And after 1 month, after completion of therapy, the progression being picked up on a biopsy, which is positive, but the plasma sample allowed you to be able to pick up or reflect upon slightly earlier. So it is around 2 to 3 months earlier. You are able to pick up this mutation profiling and helping you note that whether this disease is there or not. So in these settings as well, liquid biopsy settings, this mutation profiling or genomics is being described. So what we are doing as at the moment in the Indian settings, or what we are doing is we've been doing for the characterization of those lymphomas. We do have an assay. This is a 60 gene DNA based FFP DNA based assay where we try to characterize this B cell and T cell lymphoma. So this is available. We also we have developed, and it is in validation, 2 additional assays like LymphoTrack 360 for the monitoring purposes, and this is available for a trial settings. Also, we have trying to develop a larger 500 gene NGS assay. So whatever assay similar to the LymphoDX assay 60 gene assay, some other companies also have such panels. So the point is that yes, a lot of work has gone ahead in characterization of the diffuse large B-cell lymphomas and improving our understanding. There are few assays which are available in Indian settings to be able to help you characterize them further. But more work, more trial, more data needs to be there to be able to put up into the perspective that we need. And hopefully in the coming 3 to 4 years, with the availability of various trials, we should be in a position to get that. And with that, I would like to thank you all for your patient listening, and hope this is useful. And I'll be happy to take any questions if they are there.
Thank you, Neeraj. Beautiful. Enjoyed. So we'll go for the questions. Yes. The GCB, ABC, and then there is the third group where we do not know.
Yeah.
What should a clinician do as far as the treatment of that third group is concerned?
I don't know, sir, whether your choice of therapy varies in terms of R-CHOP is what you would offer, or you would differ in terms of the. I am not sure whether it will differ. It is mostly the same is what you would offer them.
Yeah, as you mentioned that if it is ABC type, then we try to give Pola.
Yeah.
If it is GCB, then we avoid Pola.
Yeah.
And if it is double hit or dark zone, then we give more aggressive protocol, which is the infusional therapy, DARE, POC, where the drugs are given as continuous infusion. So overall, we just have these three protocols.
Yeah.
In clinical practice, addition of ibrutinib or lenalidomide hasn't really become a standard of care. I mean, there are people who use it, but it's not the standard of care, at least at the moment, because we don't even have the molecular data available in the patients. So as a clinician, okay, we don't have too many options. We just use three protocols.
Yes, sir. R-CHOP is what I would say. Maybe in terms of guiding the prognostic-wise information, that is where the counseling-wise it might be different.
Right. So how much of all that what you spoke, we can ask you to do for our patient in day-to-day practice?
So so one panel DNA based is available, sir, and this is not from us. Some other companies are also offering that, and the thing here is to be able to get you the subtype mutational profiling subtype. You know, it could be MCD type, Notch1, TP53 positive. So that kind of information we can get. What we the different approaches that even the other approach is that you don't need to do anything. You send an assay. We will do mutation, fusion, CNV, everything in terms. That is where we are working. So going forward, further you send an assay, maybe IGH, BCL2, BCL6 rearrangement along with the various mutation profiling also would be available in the same assay. So that is where in another 3-4 months, some assays will be available. The challenge is in the picking up the dark zone signature, so that we won't be able to pick up, and we need an expression or an RNA based express assay because nanostring is not available, and that is where challenge is there. So there is an alternate approach. Maybe an assay would be available. I have tried to work with various agencies, but still it doesn't look that we will be able to offer that as an assay in going forward. Not at the moment in clinical grade, but yes, if you ask me to do for an assay on research grade, we can do that. We can do that to pick up, but that is again on research mode, not in the clinical mode as yet. So those in clinical grade, going further, mutation profiling, fusion, CNV, this kind of thing can be done. And plasma monitoring based also can be available. So this is also available, but again, we need more data to be able to see that, okay, I have got this 4 mutation, I have done a diagnosis, this was available. Now for follow-up patient, so this has come down. So that understanding will come as we do more cases. We have done that. I have done some cases. It is working very nice. So you can say that there is mutation present or absent and various different mutations, but then using that information for my follow-up data and then interpret that data, that is where we need more testing to be able to do that.
If for a lymph node of DLBCL diagnosis, if CD10 is positive and MUM1 is also positive, how will you classify that kind of lymphoma?
So difficult again. Maybe mutation profiling will have some whenever the discrepancy is there where you are not able to characterize that based on the mutation profiling, at least we can get some insight, because usually this does not happen, but rarely some of the interpretation issues are there based on the FFP, and there some mutations might help guide. Okay, this is MCD positive or what, and we are able to position them in a better way, because there will be some objective marker available again.
Right. Dr. Shilpi Saxena, your question.
Thank you, sir. Thank you for the wonderful lecture. Sir, actually, I had a patient long time back. So young lady, 28 years old, she presented with huge axillary lymph nodes. So we did FNAC and I took out some material for flow also. So on flow, we had kappa restricted, almost all the cells were kappa restricted. So on the basis of morphology and flow findings, we gave it as suspicious of high-grade DLBCL. But unfortunately, the patient was lost to follow-up after 1 month when she came. At that point of time, when we did the FNAC, the LDH was 300. So after 1 month when she came, she had a disseminated disease and we lost the patient. So in such cases, sir, if the patient is unwilling for biopsy, or can we do something on the FNAC material
Yeah.
to
So
diagnose?
so
Because at that point of time, the conflict was whether it is Burkitt or it is DLBCL. Without the diagnosis, we cannot start the treatment. Unfortunately, patient was lost to follow-up, so it's just retrospectively, I just want to
So
dissect
what
the.
we can do, we can certainly characterize using the FNAC specimen. It is very
Okay,
similar
sir.
to whatever the material we use from FFP. We can use that. Still, the diagnostic part is morpho.
Yeah,
It has to be histopathology in terms of diagnosis. So I will be able to share with you that this is the mutation profiling, but
sir.
if we are not able to take a direct call, because histopathology forms the background. That is why I started with histopathology. Still,
Sir.
diagnostic aspect is histopathology. It has not reached to a point where, based on mutation profiling, I will say that this is this entity is not there as yet. Going forward, it will happen. But yes, mutation profiling, if it is helpful for your treatment implications or diagnostic implications, and using that specimen, we can characterize that. And again, it is empirical that what panel we select. Using a panel which is suited to leukemia versus a panel which is suited to lymphoma, and which covers everything versus only DLBCL. So that selection of the panel will be important there. But we can do that.
Thank you, sir.
Even for plasma also we can do.
Thank you. Dr. Amit Khurana.
Dr. Neeraj, wonderful talk. I just wanted to know, you said about a dark zone signature. Basically, they are usually FISH negative, 60% of the cases.
Yeah.
FISH BCL2 and MYC negative, right? So they come into Germinal Center BCL, like we will think that this is a good prognosis.
Yes.
So how do you catch about that this can be a dark zone signature based on
That is
the
what I was. So basically, what I want to say is that
whom to
within
submit for
GCB,
dark zone signature? The
so
question
there is, at the moment, there is no assay available to help you pick up. The description is DLBCL 90, a nanostring based assay, being not available in India. But there are alternative approaches being considered to pick up this dark zone signature, and complete RNA-seq or a transcriptome-based assay is also being described. I have not shared that in detail because that is, otherwise we will go away from that. But then if you need that to be able to pick up, then people are trying to work up an alternative method similar to IHC. This is NGS RNA based assay to help you pick up dark zone signature. But then that assay will do only that. It won't help you any other things. It can be done. But the most gold standard is the nanostring based assay, which is not available. And we are missing out 60% of our poor prognosis cases in GCB.
So should we subject all the cases for this assays?
That is where this is, we are moving, that we are, some of the GCBs which you know that, you say that they should do good, they do bad. You understand that in terms of clinic. Well, now we are trying, have a genomic signature for those cases.
Thank you.
Neeraj, if you have a GCB type and it is EBV positive,
Yes, sir.
well, what will it signify? What a clinician should do in that? Take it as a poor prognostic?
EBV positivity, again, whether this is plasma positivity or
Tissue.
tissue positivity, and usually it is poor prognosis only, sir. I mean, EBV positivity, EBV positive DLBCL is not good. I mean, it is and again, sir, I mean, there are assays available where EBV positivity also could be described. On the same assay, you will have mutation, fusion, CNV, dark zone, signature, rearrangements. This is clonal or non-clonal, and EBV positivity. So that is where, if the way is that if I am able to give a single assay, everything in one assay, for sure they will not do good, they will do bad. But you will have an objective method of doing it in the lab.
Right. Any other question for Dr. Neeraj?
Sir, immunodeficiency, HIV positivity and all, those are also important whenever we have EBV positivity, and they need to ruled out whenever we have that immunodeficiency. Those things we need to.
Sure. Yeah. Question coming up in the chat box. How early we have to screen 2 children, 1 and 3 years old males, healthy, good growth, fathered by a lung lymphoma, treated 35 years old male. Then the question is that there's a 35 years old male who has been treated for lung lymphoma, and should you screen children aged 1 and 3 years who are otherwise fine?
As such, so we don't do that, sir. We don't do that.
I don't know the basis of this question, but anyway. Another question that has come up is, can we diagnose DLBCL on the basis of smear?
Smear, in the sense, it is bone marrow. You can make a suggestion, or you can guess that this is there. On flow also, you can try to suspect that. But histopathology or biopsy is the gold standard in terms of saying that this is large and smear. But yes, you can have an assessment of those cells. Those are large in terms of morphology. You could make a suggestion that, but you need a biopsy for an IHC for calling.
Absolutely. That is in the chat box. Any other question here? We have 2 minutes left.
Hello.
Oh, hello, sir.
Oh, that's good. I hear it fine.
Yeah. So we will go on with the second lecture. Thank you so much, Neeraj.
Thank you, sir.
Enjoyed your talk. And I will share my screen to introduce the next speaker. So Dr. Zurzak from Poland has spoken to us multiple times, and he was with us in Mumbai as well. You all know him extremely well. He's MD, PhD, consultant and professor of hematology at National Research Institute of Oncology in Poland. He's a consultant professor of hematology at the university, and he leads the lymphoma team there from 1992. Most of his research activity in the first 15 years is related to development of monoclonal antibodies in B-cell lymphomas and practical aspects of stem cell transplantation. The university he leads, he has participated in over 70 clinical trials, including phase 1 and phase 1 followed by expansion cohorts. He's co-author of publications leading to registration of ibrutinib, adalimumab, belinostat, lenalidomide, venetoclax, and rituximab biosimilars. At present, his research is focused on developing future generations of BTK inhibitors, anti-PD-1 molecules, DARTs, and BiTEs. He's a member of numerous scientific societies, ASH, ASCO, others, and consultant for EMA. His research papers have been published in NEJM, Blood, JCO, Lancet, Lancet Oncology, Annals of Oncology, with community IF more than 650, H-index 20, and citations more than 3,000. Today, he'll be speaking to us on novel agents in the field of chronic lymphocytic leukemia. I'll stop here and hand over the platform to him.
Thank you very much indeed for this kind invitation, Professor Agrawal. I just want to compliment your consistency. You're indestructible in making this online meetings now over and over again. Let me just try to share my screen.
Yeah, we can see it.
So I think I have 25 minutes or so, so I'll just start from CLL highlights on EHA 2026, which were held in Stockholm, so a much nicer city than Krakow, where I come from. And in CLL, we all agree that there's a long way we went through. We started from chemotherapy, then immunochemotherapy was the standard of care, followed by BTK inhibitor monotherapy, and eventually coexistence of BCL2 and BTK inhibitor-based approaches. To make it even more clear, in 2008, chlorambucil allowed us to achieve a 6-year overall survival of in half of the patients, but progression-free survival in less than 20%. Bendamustine rituximab did not improve progression-free survival a lot, and the first revolution was ibrutinib. After we published a paper in 2013, it was granted accelerated approval after the second phase study in relapsing refractory patients. Venetoclax followed in combination with obinutuzumab, but if you look at it, there was no major improvement, whichever the BTK inhibitor we used, and perhaps a triplet might be better in terms of overall survival, but this is to be proven and definitely not in all patients. Now, we all agree that we use venetoclax-based time-limited regimens in those with a mutated EGHV status with a low-risk disease. In unmutated patients, it's a draw. We can choose, while in those with 17p deletion TP53 mutation, we still tend to prefer the BTK continuous therapy or the combination of BTK and BCL2. What we had on EHA conference was a concomitant publication of CLL treatment guidelines. And this I'm quite proud of, as I am one of the members of the EHA guidelines committee responsible for lymphoproliferative disorders. And Professor Einhorst and Paolo Ghia did a great job because they not just summarized all we know, but they used different colors or different intensity of green to express somehow unwritten attitude of the whole committee preparing the guidelines of what is most to least recommended. But the other thing they've done the same thing. So it was a color game as well, but taking a risk of infection and ease of treatment, possible complications, so that to demonstrate that something like ideal therapy for everyone, it does not exist. We simply have a variety of possibilities to choose from, and we have to look at an individual patient because certainly it's genetics guided. However, we may have a lot of other patients as candidates for the indefinite BTK inhibition, specifically if you're talking about the elderly and comorbid patients to whom the first line of anti-CLL therapy will be possibly the last one in their life, or just those with some problems, logistical problems or whatever. But if we have a young 70-year-old one who is willing to have 100% of his life back, and we can risk slightly more, a time-limited combination therapy should be regarded as the best option. Perhaps not in a crippled individual who, whatever we say, will never, and whatever we do, will never have 100% of his life back, and perhaps he is a more likely candidate for BTK monotherapy. And at the era where we like the combinations, time-limited combination, I just want to draw a conclusion to the fact that BTK monotherapy stands on a very solid ground with nearly 2,000 of patients in different clinical studies, and we have a very well-established second and third line if necessary. Now, the other study, which was not presented at EHA, but it was widely discussed on the EHA meeting, was the CLL-17, published by Al-Sawaf and co-workers in New England this year. And 1,000 patients were randomized to 3 arms, including continuous ibrutinib, venetoclax and obinutuzumab, and venetoclax and ibrutinib. And the population was slightly younger than we would have expected in a real-life experience, but otherwise, with 56% of unmutated EGHV status and 7 to 8% of patients with 17p deletion or mutation, they were more or less what we would have expected. Now, as you see, the most of neutropenia was observed in venetoclax obinutuzumab arm, most of atrial fibrillation in ibrutinib arm, which was straightforward. But although the infections were even, the grade 3 or greater infections were predominantly observed in venetoclax obinutuzumab arm, and it was predominantly due to COVID-19. And if progression-free survival was even, regardless of the arm, I want to draw attention to the fact that overall, we started to observe the difference, and venetoclax obinutuzumab was inferior to other arms due to COVID-related mortality. So, the continuous BTK inhibitors are still preferred in treatment-naive patients in certain conditions we already mentioned. Now, the Sequoia study, which was the Zanubrutinib randomized a study in the first arm, demonstrated a clear superiority of BTK inhibitor with 86% of those progression-free survival without any problem at 72 months with a mutated status, and 72.5% with those with unmutated status, a very good result, including 64% progression-free survival of those with mutation of p53 or 17p deletion, regardless the EGHV status. And what was presented on EHA was a 7-year follow-up and a progression-free survival too. So we looked at how the patients were treated after relapsing, and it was evident that after relapsing from Zanubrutinib, half of them were treated with BCL2 inhibitors. After relapsing from chemoimmunotherapy, most of them were treated by BTK inhibition. And regardless how they were treated, the time to the second progression was still better for the patients who were upfront treated by Zanubrutinib. Now, what we've done with Talamonea, we've done a MAIC analysis because we wanted to assess whether ibrutinib-based conclusions could be generalized to Zanubrutinib, or perhaps other BTK inhibitors might be better than ibrutinib in CLL-17 study. So we went for matching adjusted indirect comparisons unfortunately unanchored, because an unanchored MHG is a much more risky approach than if you compare two studies with a common control arm, and you have a risk of unbalanced effect of the risk factors you do not address. So again, to summarize an unanchored MHG analysis, all those studies somehow favor the protocols where we have individual patient data. So the Sequoia study was favored in this comparison, and we were able to weight the Sequoia patients to each patient was assigned a special rank, so to make the population look very similar to the CLL 17 study. We are not throwing the patients away, we were weighting them. And we are weighting them taking into consideration the risk factors. However, we might have missed some, and this what puts it under the hazard. So we took, we considered age, sex, venous stage, ECOG performance status, presence of bulky disease, genomic risk factors, cancer type. We even had to adjust the Sequoia results for COVID, as in CLL 17 ibrutinib arm, there was no COVID-related mortality. And as you see, this is a characteristics of the group before and after matching, but the effective sample size was 91 instead of 327, which might mean that it's not a very reliable study. Whether the results are smashing, because before adjusting Zanubrutinib, it's this middle curve is more or less like ibrutinib. After adjusting, it is absolutely better, and it's no magic, just maths, where we demonstrated the improved PFS and numerically favorable overall survival of Zanubrutinib from Sequoia compared to ibrutinib. Therefore, if Zanubrutinib were a competitor arm, the Sequoia study results might be different. And the further proof that Zanubrutinib might be a better BTK inhibitor came from a relapsing refractory setting. And if you look at the PFS at the first 3 and 4 years, there seems to be no difference, but after 6 years, there seems to be a substantial difference favoring Zanubrutinib. And the last confirmation comes from 2 randomized studies where in Alpine Zanubrutinib was compared to ibrutinib in relapsing refractory patients, and you can see that in all populations we could demonstrate Zanubrutinib's superiority in terms of progression-free survival, while in Elevate relapsing refractory we could demonstrate just a non-inferiority of acalabrutinib, although this was the high-risk group. And it's always easier to demonstrate the difference in high-risk group just to show how it will look in the Alpine. That's a high risk from Alpine. The next part, I want to shortly discuss with you what new drugs do we have in chronic lymphocytic leukemia. And this is partly the speech I gave at New Drugs in Hematology held in Bologna this year. And the new drugs we tend to use in a truly bad patients. And most of those clinical studies should and are performed in a double refractory patients, which are far worse than a double exposed patients. And we have to make this definition because double exposed patient does not necessarily mean the worst of the worst. If you look at the resistance to BTK mutations, you can see that they are quite common in covalent BTK inhibitors, and non-covalent inhibitors like pirtobrutinib address part of those mutations, specifically C481, and are an effective salvage for the patients refractory to the first and second generation. However, if you look at both BTK degraders, they are much, much more effective in terms of overcoming resistance. And Bexobrutideg is one of the two degraders. By the way, Nurix was a small company, but recently the Bexobrutideg was acquired by Roche, which will make the competition against B1 more even. And it has a different mode of action. It does not inhibit Bruton tyrosine kinase. It just chops us into pieces in a mechanism utilizing proteasome. And as you see, the first study we've done in a patient failing 2 or more lines of therapy was in fact a basket study, dose finding and population finding. There were a variety of arms, including 126 patients in chronic lymphocytic leukemia, where we could clearly see that most of them were heavily pretreated, with 84% failing covalent and 27% failing non-covalent BTK inhibitors, 60% failing BCL2 inhibitors. And if you look at the mutational status, there were 40% of them with BTK mutations, 40% with TP53 mutations, and specifically even 8% with PLCG2 mutation, which is a hallmark of inefficacy of BTK pathway. The drug was pretty well tolerated apart from a grade 3 neutropenia, which was manageable, and this regardless the dose we used. And what I want to demonstrate was in CLL, there was a considerable efficacy allowing PR in terms of lymph node reduction in over 80% of patients, as you see on the bottom chart, regardless of the mutational status. And certainly, the subgroup analysis confirmed what we already mentioned, and it was absolutely certain that if someone had a prior non-covalent BTK inhibitors, they did slightly worse than the patients without it. That's the same stuff. And I'm proud to announce that 2 studies will currently be run. One is already running in a triple exposed patient, post-covalent and non-covalent BTK inhibitors and BCL2, and they are subjected to Bexobrutideg. But the other is a truly important one, the Daybreak CLL 306 study, where we will have a Bexobrutideg against Pirtobrutinib. And the Nurix people think they will win the beauty contest. Now, the other degrader is BGB16673, but it was recently named Tacobrutideg, which is a kind of a victory of a Nurix people who actually set the standard of nomenclature. Mind you, with the degraders, they will also the name will also end with deg. Then bruti stands for the protein they're degrading, and taco in the B1 drug, or Bexo in a Nurix drug, is just the name characteristic for the particle. So you have a Tacobrutideg, which is a B1 BTK degrader, already given to more than 600 patients in clinical studies. The Cadence 101 was a very similar study to the Nurix study I showed you. Multiple cohorts, multiple diagnoses, including 66 patients with chronic lymphocytic leukemia, so twice as few as in Nurix study. A very similar molecular characteristics, very good tolerance. We had only neutropenia and perhaps more pneumonias of infections. The groups are too small, but we didn't observe it in Bexobrutideg. The cytopenia was corrected very fast, and this is just to show you how the thrombocytopenia was dealt with after initiating of therapy. We achieved 84% of response rate, including responses in a high-risk group, like 75% of responses in triple exposure, 81% in those with TP53 mutation. So all the degraders are absolutely fabulous. That's cadence progression-free survival in CLL patients, with 73% at 12 months and 66% at 18 months. And that was regardless the site of the mutations observed in the patient treated. The cadence the Cadence 104 study is in fact combining the way they want to explore the combination of tacrolimus with sonrotoclax, zanubrutinib, mosunetuzumab, or glofitamab. But I would like to draw attention to 3 randomized studies. In the first, the tacrolimus is randomized against investigator's choice, and this is in a triply exposed patient. Then the same study that Nurix is going to run, and this study is already recruiting. So tacrolimus versus pirtobrutinib in those who are exposed to covalent BTK inhibitors. So in both instances, both companies are running the studies against pirtobrutinib, and both companies are hoping for the swift run. Both BTK inhibitors and BTK degraders are given as a time continuous therapy, and this made me make this picture as I was giving this lecture in Italy, that in a Roman army, in Roman legions, when the battle was truly bad, they had 3 lines of infantry, with the 3rd line being most experienced and usually left until the very end of the battle. So if the battle was harsh, it had to rely on this 3rd line, which might be continuous therapy. Just last a couple of minutes about BCL2 inhibitors, which have a magnificent effect, causing deep molecular responses. And we went far beyond venetoclax. And I just want to draw my attention to sonrotoclax, already given to more than 2,000 patients, which has a 14-fold higher biochemical potency, 6-fold higher selectivity, which has a shorter half-life, therefore allowing for less risky ramp-up, and which may address venetoclax resistance mutations. The second phase study in relapsing refractory CLL revealed over 77% response rate, and quite a remarkable progression-free survival for a monotherapy. The drug was well tolerated, with just 30% of grade 3 neutropenias. However, what's really hot is that B1 has in one stable 2 racing horses. They have sonrotoclax and zanubrutinib, and this combination sounds to be one of the most promising combination in CLL. And this is a dose-finding study, which I want to spare you the details for the sake of time, but look at progression-free survival. And if you do it in the treatment-naive patients, not talking about MRD, look at the progression-free survival. It's a straight line. This combination is a well-tolerated killer. And there are 3 ongoing studies exploring sonrotoclax zanubrutinib combination, and this is the most important one, where sonrotoclax with zanubrutinib is challenging venetoclax plus acalabrutinib, and again B1 hopes for the swift win, which is probably possible. And there are 2 other studies as well. Just one word about lisafluflax, a fancy BCL2 inhibitor, the only one which allows for a very fast ramp-up, because we're able to do it in 5 days. With epcoritamab, we are not expecting a lot, as we are having patients with a longly distorted immunity, and it does not work as well as we would have expected, judging from our experience from diffuse large B-cell lymphoma or follicular lymphoma. So instead of conclusions, just to leave some time for discussions, we could say that clinical studies were never so fascinating. However, established standards of care, they do not last long. Thank you.
Thank you, sir. That was fascinating. Enjoyed listening to you. You took us way forward from what knowledge we possess so far. Wonderful. So we'll have some discussion, and till I see my colleagues raising their hand, can I ask you the starting question? So in your practice now, between the continuous therapy and the fixed duration therapy, what has been your preferred modality?
Continuous duration. Well, I'm looking at the patient.
So how do you decide based on the patient?
Just cytogenetics will do the trick. I think that we have a variety of options, and we no longer have to follow the same route. I would say, for example, that ibrutinib should never be, unless it's sold in a price of chlorambucil. Then, if it is a generic drug, it will regain its charm. But for whatever the reason that Janssen & Janssen went the way the lenalidomide people did, and they keep on prolonging patent rights. So I think that nowadays, this is the only drug I would not recommend to use, unless very cheap, with one possible exception is just before the CAR T-cell therapy, as we might have the data that with the CAR T-cells, not in CLL, ibrutinib is increasing the strength of the T-cells. But with the other BTK inhibitors, all of them have their charm. Presumably, acalabrutinib is less toxic, zanubrutinib is possibly more effective, but I would say that pirtobrutinib is even more effective than zanubrutinib. So it's fairly likely that after the data we presented in last ASH meeting, namely BRUIN 313 and 314 study, it's likely that pirto will be approved in the first line as well. And then we could choose between the best BTK inhibitor we want. However, I would say that I would like to be able to block BTK pathway twice in the patient life. So I would either use the best BTK inhibitor in elderly and comorbid patient who is unlikely to live long enough to need a second line of therapy, or I would use the non-covalent BTK inhibitor in the first line only after there is an approved BTK degrader. Now, I do not believe in endless blocking of BTK pathway. Now, the BCL2, so venetoclax with obinutuzumab sounds to be the best and the most widely used therapy in a low-risk mutated patients without any other cytogenetic abnormalities. I'm saying fine, but again, if we have a very crippled individual, perhaps it's too much. If I went for the combination, I would truly like to go for AV or AVO regimens, although I'll never risk AVO regimen in the elderly patient or in someone who is not vaccinated for COVID. Last but not least, you heard my story about someone, a patient, who wants 100% of his life back. And I believe in this. If you have that individual who's in a full swing, who does not look like elderly. So if I were to treat you, I would definitely persuade you to go for the doublet. I would never give you a BTK monotherapy. But if I see someone who is not doing anything with his life and is just spending his life watching television and doing nothing, perhaps I would just give him BTK as a monotherapy.
Thank you. Interesting answer. Yes. Questions from the colleagues? Meanwhile, when you're giving a fixed duration therapy, you will prefer Obinu with venetoclax or a BTKI with venetoclax?
BTK plus venetoclax. For one reason, 2 tablets and less infections. Obinutuzumab is a difficult drug to use and is causing a lot of infections.
And
however, I understand that if you have a mutated low-risk patient, majority of us will go for VO, venetoclax and obinutuzumab.
now, obinutuzumab is superior to rituximab, but the cost difference is huge. In the sense, rituximab is generic, obinutuzumab is not generic.
But it's a very, very important point you raised, because in all the disease, on all other lymphomas, like in mantle cell lymphoma, I would never use obinutuzumab. It's pointless. However, in CLL, we have such a dim CD20 expression that we really need a stronger monoclonal. So I would advocate either to use obinutuzumab or not to use anti-CD20 at all.
Okay. Now, in the relapse
But just for CLL, not for mantle cell lymphoma.
Yeah, that's a wonderful explanation. In relapse setting, it was rituximab. Was it from the angle that Obinu was used upfront or otherwise?
Don't ask me, it's illogical.
Okay.
Making the long story short, I never use it. If I have to use venetoclax in relapsing refractory setting, I use it with obinutuzumab, and I don't pay a shit about the Murano study. I call Murano study the victory under Murano. It was a genuine study showing an important difference. But now we know that we can make it better.
Right. When you give fixed duration therapy, you are going with a fixed duration or you are looking at the MRD?
Well, everyone is crazy about MRD. May I be blunt? I don't pay a shit about MRD. It's just a prognostic factor. You never cure the patient. It just lets you know what the prognosis is likely to be. And for me, if you're talking about the disease like CLL, which is a very common disorder of elderly patients having a lot of logistical problems, I would never like to see the treatment guided by MRD in 90% of the patients. The question, there is 10% of patients who use MRD, and this 10% are the patients treated with a time-limited therapy. However, if I have a 50-year-old one in CLL, if I have a true youngster, someone to whom the result of a standard of care means nothing fascinating, at least treating these patients in a different way makes them feel special, And at least somewhere between us and the patient, we may say, well, the prognosis is not magnificent because you're young. You might eventually die, not with, but because of your CLL. However, we are doing our best. You are on a special target. And I don't see any way MRD could be done in a district centers. It's a loss of time because you either do MRD very precisely or you don't do it at all. There's no point in having thousands of labs doing MRD in a wrong way. It's better to have a couple of labs doing it in a good way, possibly in a bigger centers where those younger patients should be directed to.
Sure. You will ever advocate the triplet?
Triplet?
Although
Yes. In a well-vaccinated youngster, why not?
the risk of infection.
We have treated a lot of patients with AVO. We never lost anyone to COVID for one reason. We do a lot of clinical studies, and I have my own private exclusion criteria. Which my collaborators say that that's professor's exclusion criterion. And it is that clinical studies are not for idiots. So I do not take any anti-vaxxers.
So when you use such aggressive protocol, you have a lot of antimicrobial prophylaxis?
Well, I'm saying yes and no. Not antibacterial. We are using cotrimoxazole with trimethoprim, but I'm not convinced it's necessary. And we're using a cyclovir, but not in the patients vaccinated to
Herpes zoster.
To herpes zoster. And CLL is a disease where, let's face it, in majority of cases, we have some time during which we can educate the patient and vaccinate them. If I have the anti-vaxxer entering my office, I'm not trying to change his mind. I'm even saying, well, perhaps you're right. I don't know. But I just want to speak with you as you have the neoplastic disease of the immune system. And then this particular subgroup of patients, I'm the expert. In the general population, I don't want to argue with you. And sometimes, and it depends who is the doctor. I'm saying that I have a 60% success rate in converting the anti-vaxxers to fully vaccinated patients. Some of my colleagues have a 30% success rate. You know, you have to be persistent.
Sure. When you're using venetoclax, and if you have significant neutropenia, you drop the dose of venetoclax or you keep pushing GCSF?
May I just say something in a whisper? Perhaps 60% of the patients are having 400 milligrams of venetoclax. The other 40%, I would say that 30% never reach 400 milligrams. I just stop the rampage at 200. But I never mentioned this.
But from the angle of fixed duration, you won't like to push the drug hard with GCSF?
Well, my point of view is that you still have a good couple of months. If I had just 6 cycles, I would say, well, perhaps, but it's longer. So, no.
Okay.
If they need a GCSF during the rampage, I don't make it higher.
Right.
But mind you, some of those patients are actually having the neutropenia because of a bone marrow infiltration. So some of those patients, even if they are cytopenic, they will eventually do better. So it's not once and forever. But I'm not. I do not insist on pushing the drugs too far. I'm not in. They say you shouldn't do the break in the drugs. But let's take BTK inhibitors. I never ask the patient to take the drugs whenever they have other medical problems and specifically infection. And our system is organized in a way that infections are dealt with general practitioners, not by us, specifically if the patient comes to see us from a distance. So I'm making a rule to all BTK inhibitor patients that if you go to the doctor with a serious problem, you get it treated the way the doctor wants to, but you stop your BTK inhibitor before and then try to contact us. But if you go to the doctor with something which is a minor problem, not the infection, you keep on taking BTK inhibitor and do not take the drug the doctor prescribes you before contacting us. And in a way, I encourage them to stop BTK inhibitors every time they have infection, because I think that that allows them to have the infection cured more efficiently and faster with all the drugs the general practitioners have practice with during the particular infection period they observe. They don't have to do anything different. At the same time, the immunity is not down-regulated, and infections, they never last more than 10 days, so it doesn't matter from the BTK point of view. But I do not want the patients to learn the long list of drugs they are allowed or they're not allowed to take, because it never works.
Sure. Yeah.
Maybe you have a better educated society in India. We don't.
Not really. Something in the chat box. So, a TP53 mutated CLL with Richter transformation failed on R-CHOP, planned for POLA-based regime, MST available. Would you prefer allo transplant or CAR-T?
CLL?
Richter transformation. Will you prefer transplant versus CAR-T?
Very good idea. I mean, very good question. Because I would say that if Richter transformation is early, I would prefer CAR-T. If it's in a long-lasting CLL, I would prefer allo. However, having said so, the mortality in CAR-T is still lower than the mortality in allo. So I always discuss the risk with the patient, and they have to know what are the possibilities of failure or reasons of failure. We do less and less allo even in Richters.
Right. Another question is about ITP in a patient of CLL. Will you start treatment of CLL or always give steroids only?
Well, I mean, it does depend how important thrombocytopenia is. And it does depend whether it's a pure ITP or we have also splenomegaly. If we have important thrombocytopenia and splenomegaly, I would say that treating CLL would be, in a standard way, would be fully justified. If we have just episodic ITP, and specifically in a patient who is not well prepared to begin therapy, who needs to see his stomatologist, who is not vaccinated, I would rather treat his ITP first and then give him time to prepare for a proper CLL therapy. But if episodes are relapsing, it's better to give patients long-time BTK inhibitor than long-time steroid.
Right. When do you give another BTKI after you have used it as the first line?
BTK after BTK.
Yeah.
It's like whiskey with whiskey in a glass after whiskey. Well, cutting this long story short, I tend to give BCL2 after BTK inhibitors unless I have to. But if I have a 17p deleted patient, I do all I may to change to non-covalent or to BTK degraders.
Right. Are you comfortable using venetoclax in elderly people above 70?
Yes. In fact, I would say that if we are talking about the low-risk patients with a mutated EGHV status, perhaps up to 70% of them in Poland will get venetoclax and obinutuzumab.
There's a patient with cardiac dysfunction having left ventricular ejection fraction of 35%. Will you prefer Zanu over other BTKIs?
Well, it all depends what kind of cardiac dysfunction is it. We are certain that atrial fibrillation is the problem with ibrutinib. We know that if the cardiac dysfunction might be caused at least partly by the hypertension, then acalabrutinib might be better than zanubrutinib. With venetoclax, it's given with obinutuzumab, so more taken together, preventing tumor-Luzer syndrome and everything, you usually have a volume overload. So it's not like that acalabrutinib is killing the patient while venetoclax obinutuzumab is without any buts and ifs. So you have to look at how severely impaired the patient is, and I would definitely advocate the idea of not giving ibrutinib to those patients, but whether the better BTK inhibitor or venetoclax, it's for me disputable.
Yeah. Your venetoclax-based therapy is for 1 year or 2 years?
Well, first line, officially it's 1 year. Second line, officially it's 2 years. But we are just the slaves of the clinical studies. Shall I give you one example? Could we stop BTK inhibitors? Well, theoretically, we should not. But we had a lot of patients who were discontinued on BTK inhibitors because, for example, the companies didn't develop those inhibitors anymore. They achieved a good partial regression, as with BTK, and they were discontinued. And I observed them for 1, 2, sometimes 4 years without the necessity of retreatment. So I do understand that with venetoclax or BCL2 inhibitor-based regimens, we have a deeper responses, allowing us for a longer break in therapy. That's why we call it a fixed time therapy. However, it's quite likely that if we have a patient with on a BTK inhibitor with a reasonable clinical CR, perhaps he might be discontinued as well and be without any treatment for 2 or 3 years. At least these are my observations of the cases I had to stop. What is bad in terms of disease dynamics is the situation once you're seeing a progression during therapy, but that's a different scenario because the disease is rather nasty if it's progressing while on therapy and not a couple of years after discontinuing therapy.
Thank you. Any place for venetoclax monotherapy?
I will answer it we had a paper on venetoclax monotherapy in P53 mutated patients relapsing refractory with Stilgebauer, and it worked pretty well. And my second opinion is I love sonrotoclax monotherapy. And it's a great drug because it reminds me that we had mantle cell lymphoma patients failing pirtobrutinib. They were put on sonrotoclax and they were in CR. So that's a very potent drug. Let me say that I love lisafterflax because that's the BTK, the BCL2 inhibitor. You have a rampage done within a week in a patient with 100,000 leukocytes. So we have much better BCL2 inhibitors than venetoclax, and we will use them in a nearby future. Navitoclax is gone, let's face it, maybe in multiple myeloma, but sonrotoclax and lisafterflax are much better drugs.
Sure.
And I think there is a greater difference between sonrotoclax and venetoclax than between zanubrutinib and ibrutinib.
Yeah. Right. Sonrotoclax is going to make venetoclax obsolete.
Yes.
True. Okay, that was all the question in the chat box. Anybody wants to ask anything to sir? Okay, if none, then thank you so much. We took you a lot of time and you answered all the questions very patiently. A lot of learning. Thank you. Yeah.
So thank you again for inviting me. It's always a pleasure talking to you. And congratulations on being so consistent in making those meetings.
Thank you. Thank you so much.
Thank you.
Bye. Okay. We will now move on to the panel discussion that we have. This panel discussion is on Zanu in chronic lymphocytic leukemia. Once again, an update from EHA 2026. So we have our panelists here, Dr. Anant Gokarn from Mumbai, Dr. Arijit Bishnu, Kolkata, Dr. Asif Iqbal, Guwahati, Dr. Kundan Mishra, Lucknow, Dr. Monisha, Kochi, Dr. Revanth Bodu, Bangalore, Dr. S.P. Verma, Lucknow, Dr. Tribikram Panda from Bhubaneswar, and Dr. Upendra Sharma from Jaipur. And I hope most of them are there with us. As you know that progress of CLL from the angle of treatment has been phenomenal. We just had our colleague describing how we have moved from chlorambucil right up to the right half of this slide, where in the red you are seeing the targeted therapies. Ibrutinib, almost about more than a decade ago. Venetoclax, about exactly a decade ago. And then Acala, and now Zanu. So we have made tremendous progress with these agents. As far as the BTKI are concerned, we have these three musketeers, the Ibru, the Acala, and the Zanu, in that order in which they came, and in the order of their safety and efficacy. As was told by a professor, Ibru is something which you will never use in your practice. It is the poorest in its efficacy and the worst with respect to its adverse effects. Acala became popular because it was safer, but efficacy remained the same. And now you have Zanu, the new kid on the block, which is superior in efficacy and better in safety, and therefore it has good of both the worlds. When we seek a BTK inhibitor for a patient of CLL, we are not just choosing a drug for today. We are choosing its clinical trajectory for the next 5 to 10 years. Every agent in this class can shrink a tumor, and the tumor here is CLL. But our desire is not simply adequate disease control. So the real test of our choice happens in the margins. That is when a high-risk clone mutates, when a patient takes a unprescribed over-the-counter antacid, or when a sudden arrhythmia forces us to abandon our primary line of defense. Today, we will discuss why Zanu is the only BTKI designated to eliminate these exact real-world vulnerabilities, offering superior efficacy where it matters most, without forcing our patients to compromise their cardiovascular safety or the lifestyle independence. At EHA 2026 Congress, data reinforced that Zanu-based regimens deliver superior progression-free survival, deeper MRD clearance, and a highly favorable cardiovascular safety profile compared to the earlier generation covalent BTK inhibitors, establishing Zanu now as the next generation targeted monotherapy or in combination, becoming the standard of care both in frontline and in the relapse refractory setting in CLL. With that, we begin with the first part. And the first part is Zanu monotherapy long-term efficacy data presented during EHA 2026. Long-term responses to Zanu in patients with CLL, and the question to the panelists: what long-term progression-free survival and overall survival data from EHA 2026 support the frontline use of Zanu monotherapy in a newly diagnosed CLL as against the earlier BTK inhibitors? The question is not addressed to any one particular panelist. Any one of you can take it up for discussion, and we have some slides as well.
So, as far as this year 2026, sir, am I audible?
You are audible.
Thank you, sir. So, as far as the data from EHA 2026 is concerned, the long-term data, short-term as well as the long-term, including the 72 months indirect comparison of this Zanubrutinib versus Ibrutinib has already been demonstrated, and the PFS as well as OS both are in favor of Zanubrutinib. So, as a monotherapy, Zanubrutinib is definitely superior in comparison to Ibrutinib, and not only that, but even with Acalabrutinib, it has shown that it is relatively superior. It is better. Though earlier Acalabrutinib was shown non-inferior to Ibrutinib, but in this data presented in 2026, Zanubrutinib has been shown to be superior in comparison to Ibrutinib. So data as monotherapy for Zanu is much better, sir, as far as OS and PFS is concerned.
Thank you. Would the others like to add anything? Okay, so this is Zanu giving complete and sustained BTK target occupancy. Now, each word is important: complete and sustained. This happens both in blood as well as in the tissue, that is lymph node in the marrow, 100% occupancy. So that is achieved by Zanu, and it is maintained. It demonstrates complete and sustained target engagement even in the dense lymphatic tissues. It ensures uninterrupted pathway inhibition over the entire dosing interval. So this is very important, that as against the earlier BTK, you got this 100% occupancy, and that is sustained, and that's both in the blood as well as in the tissue. This results in extremely durable clonal suppression in a newly diagnosed CLL. In EHA 2026, there was updated long-term follow-up data, as well as multi-trial cross comparisons, such as at the end of 72 months, that is 6 years, indirect comparative analysis of Secure study for Zen, Resonate 2 study of Ibru, and Elevate TN study of Acala. They demonstrated that Zanu, as the first-line therapy in the newly diagnosed CLL, produces superior progression-free survival and overall survival, as was just mentioned. This is the data between IBRU and Zanu. IBRU, the overall response rate of 62.5%, Zanu 78.3%. This is a Italian cohort, real world safety and effectiveness of Zanu versus IBRU. And if you look at the conclusion, the findings provided real world evidence that Zanu achieves more durable disease control and greater treatment persistence than IBRU. So Zanu shows strong 6-year efficacy in frontline CLL. We move to the question 2. How does the genomic high-risk profile, including deletion 17p, TP53 aberrated CLL, unmutated IGHV, and complex karyotype, influence the long-term therapeutic durability of Zanu monotherapy? Once again, any one of you.
Thank you, sir. So can I take this question, sir? Okay. So as far as the CLL is concerned, so 17p deletion, TP53 mutation, complex karyotype, IGVH unmutated status, all these are actually very much high risk prognostic classifications. So as all of us know, this BTK inhibitor, yes, it is the treatment modality of choice in TP53 or deletion 17p cases, but Zanubrutinib, irrespective of all these high risk factors, it performs well. So as we have already seen, the data is robust, and this 5-year PFS is 72% in the Sequoia arm series. Okay, so again, this Zanubrutinib as compared to other chemoimmunotherapy like FCR or BR or first generation BTK inhibitors, it gives a deep sustained actually PFS benefit with deep targeted disease control as compared to conventional chemoimmunotherapy or first generation BTK inhibitors, as we have already seen in the Sequoia trial in the newly diagnosed cohort or in the Alpine trial in the relapsed refractory cohort. So it is effective.
Right. In Sequoia trial, the C arm was essentially deletion 17p arm. Wonderful. Others want to add anything? Okay, so Zanu monotherapy successfully mitigates the adverse prognostic impact traditionally associated with all these factors which we have talked about. Long-term data confirms that the PFS curve for high-risk CLL patient treated with Zanu remains remarkably stable, avoiding the early failure typically seen with either chemoimmunotherapy, also with the first-generation covalent inhibitor like ibrutinib, by sustaining deeper target inhibition within the lymph node and the microenvironment. Long-term data from Sequoia, all arms, and the Alpine trial. Alpine trial was for the relapsed refractory patients, where it was compared with IBRU. And Sequoia, as I mentioned, the arm C was specifically for deletion 17p, but all the arms ABCD had patients of IGHV unmutated. These show that the progression-free survival rate remained flat and durable regardless of the IGHV mutation status. The continuous BTK inhibition suppresses the chronic antigen-independent C-cell receptor signaling that typically drives aggressive unmatched IGHV clone, effectively normalizing the survival curve between mutated and the unmutated CLL. About TP53, the sustained first-line efficacy in the Sequoia trial, arm C, which evaluated frontline Zanu in deletion 17p, and the 5-year progression survival, as was mentioned by our colleague, 72.2%, and the median progression-free survival was not reached at the median follow-up of 65 months. So, irrespective of the genetic aspect of the CLL, whether it is deletion 17p, TP53, complex karyotype, or IGHV unmutated, Zanu achieves the responses equal to that in a good prognostic CLL. Dr. Monica, yeah, thank you. The third question is, in the context of long-term continuous monotherapy, what did the EHA 2026 data indicate regarding the kinetics of late onset toxicity? late onset toxicities and infectious complications.
Can I take this, Dr.
Yes.
Upet?
Yeah.
So, sir, we have seen that once patient has taken this drug, Zanubrutinib, for longer duration, say for 6 to 12 months, so incidence of new onset, any grade 3-4 infections are less. And also, when patient is taking for longer duration of therapy, so the immune system further increases for these patients, and they have less tendency of getting a severe grade 3-4 cytopenias or infections with this drug. So it is a relatively safer once we are taking this for a drug for a longer duration of time.
Excellent. Others?
Yeah, good evening, sir. Just to add to that, in conditions like CLL, particularly when we are talking about Zanubrutinib monotherapy, more than the efficacy, the compliance is decided based on the safety and tolerability profile. So that is what EHA 2026 data has shown us. Even in the long term also, most of the times the complications after certain time, the curve flattens. There are no new onset of late toxicities. So that is where Zanubrutinib scores compared to the other drugs.
Excellent. Anybody else? Okay. So there is a plateauing of the late onset non-hematological toxicities. Safety is stability. Long-term continuous monotherapy cohorts show that once you pass the initial 6 to 12 months, the incidence curve for new onset high-grade off-target toxicities like cardiovascular or GI, these all flatten out. About the infections, the extended follow-up data showed that continuing Xanu monotherapy does not increase the cumulative risk of infection over the time. Unlike earlier BTKIs, where cumulative immune exhaustion or off-target myelosuppression led to late onset opportunistic infections, Xanu-treated patients exhibited stable or declining rate of grade 3 or more infections over extended periods. So this is a publication in this EHA presentation, long-term results of patients receiving Xanu in phase 3 Alpine study. As I mentioned, Alpine study is for the relapsed refractory CLL patients, where 2 arms were Xanu versus Ibrutinib. It confirms sustained benefit of Xanu in the patients of relapsed refractory CLL and small lymphocytic lymphoma up to 6 years follow-up. And it also talks about, it's not very great visibility here, but it also talks about the side effect profile, which did not increase over the period of 6 years at all. So there was no cumulative toxicity. So this much about Xanu monotherapy. We move to part 2 and talk about the combination now. So Xanu combined with venetoclax or Xanu combined with Obinu or the triplet, where Xanu is combined with both the drugs BCL2 and CD20 antibody. So question is, what is the biological rationale for combining Xanu with venetoclax? And how does this combination overcome the microenvironmental niches in CLL? Anybody?
Yeah, sir. So basically the Zanubrutinib and venetoclax, they have their synergistic effect. So Zanubrutinib moves the CLL cells out of the lymph nodes where they are, protected in the lymph nodal microenvironment, and there is down regulation of anti-apoptotic pathways and MCL1, which ultimately leads to better activity of BCL2 inhibitors. So basically, the both of them, they are in synergistic in effect and leading to quite a significant and deep response in CLL patients.
Absolutely. Anybody else? So this was the data in EHA 2026, Xanu plus venetoclax combo, 3 years clinical trial result. The summary of 3-year efficacy and safety data of Secure Arm D. Arm D was exactly this combination study. Clinical trial evaluated the fixed duration combination therapy for 114 treatment-naive CLL patients, including those with high-risk genetic features. 87% progression-free survival at 3 years. If you compare high risk versus non-high risk 87%, Without high risk, 89%, so almost same. 60% achieved undetectable MRD, so that's phenomenal. Safety profile, no new safety concern identified, no treatment-related death reported. Most common grade 3 or more adverse effects were 24% neutropenia, 9% hypertension, and 6% diarrhea. So the combination of Zanu with venetoclax is a fascinating data taking care of both high-risk CLL, giving an extremely high progression-free survival and extremely manageable safety profile. The next question is, from the safety standpoint, what sequence of administration of scheduling minimizes the risk of tumor lysis syndrome while initiating combination of Zanu with venetoclax?
Can I take this, Dr. Upin? Sir, Dr. Upin, so can I take this, sir?
Yes.
So, sir, we know that these both of these drugs have a synergistic effect. If venetoclax is used upfront, it will cause tumor lysis. So, initially, we'll give 2 to 3 months of Zanubrutinib in a lead-in phase, and thereby further we'll add venetoclax after this to prevent the tumor lysis. This will lead the patient from a bulky disease to non-bulky disease, and further reducing the risk of tumor lysis. And further, we have a ramp up of venetoclax with weekly increasing the dose from 20 to 50, 100, 200, and after 4 weeks to 500, 400 milligram. So usually this is a schedule which we should follow, but for most of our patients, we tend to combine with 100 milligram of venetoclax with azole. So by this first 2-3 months of Zanubrutinib and beating inhibitor, and then venetoclax will lead to less tumor lysis in patient with CLL. So this is a strategy where we can decrease the risk of tumor lysis and complications with patient of CLL.
Perfect. So first 2 to 3 months of Zanu, and then you add venetoclax in the ramp-up schedule. This will very significantly reduce the risk of tumor lysis syndrome, which will be, in fact, so manageable that you can do this on OPD basis without hospitalization. Wonderful. The next question is, what does the EHA 2026 consensus suggests regarding, now this is the question I had asked Professor also, regarding MRD-guided discontinuation versus a fixed duration, which may be either 12 or 24 months. So would you prefer Zanu when given for 1 or 2 years and stop? Or will you look at the MRD guided and then decide to discontinue or continue? Anyone?
Sir, can I take this?
Please.
Sir, MRD driven de-escalation is a very exciting. I think there are so many clinical trials working towards this. But there are some problems. The problem is that first, we do not have a very standard platform, whether to use a NGS platform and what depth that we will use, whether it is a flow cytometry, 10 to the power -4, -5, -6, what should be the ideal duration of time till the MRD negative status should be maintained before you can stop therapy. There is no standard. And but the fixed duration is something that we have some evidences upfront. Now, Amplify trials also showed that acalabrutinib plus venetoclax for 15 months is a very efficacious protocol. And venetoclax plus obinutuzumab is a very standard protocol, which has been there for some time. So EHA 2026 agrees that fixed duration therapy is a standard treatment which can be followed, but MRD-driven de-escalation, I think, as of yet, is not what they have recommended.
Perfect. Others? Okay. So Asif has very beautifully brought this out that first of all, you must have the facilities of reliable MRD assessment. And in the previous lecture, Professor had also mentioned that very clearly. And not every nook and corner of the country you will have that available. Second, as you mentioned, NGS-based MRD at the moment is not available in India. It's all flow-based. So you need to have expert next generation flow available to you and those labs. Having said that, yes, theoretically, at least there is a distinct advantage of either de-escalating or continuing the treatment based on MRD. And that's what is put up over here. The consensus highlights that sooner or later there will be a paradigm shift towards MRD-driven de-escalation. While fixed duration therapy, that is 12 months for the upfront and 24 months for the relapse cases, provide excellent disease control for most of the patient. Stopping the treatment based on sustained deep bone marrow undetectable MRD, which will be 10 raised to -5, -6, customizes the treatment length. This approach prevents over-treatment of low-risk clones and avoids premature cessation of high-risk patients, those who harbor persistent occult disease. Having said this, agreed, this is not what one practices anywhere in the world at the moment, but probably the world will move towards this. The next question is, why is Obinu preferred over rituximab in frontline Zanu-based combination for CLL?
So can I take this?
Yeah, please.
Yeah. So inherently, obinutuzumab is more potent than rituximab. So because it is a type 2 antibody, it has more antibody-dependent cellular toxicity and also antibody-dependent cellular phagocytosis. Also, there is some effect on direct cell lysis. So when we add obinutuzumab, there is very quick release of the CLL cells from the lymphoid tissue and quick clearance of the CLL cancer cells. So it has a synergistic action and also helps in decreasing the toxicity of the therapy as well.
Absolutely. So as was pointed out by Professor, the CD20 expression on CLL cell is very dim. So you need a strong anti-CD20 antibody. So this is the only condition in B-cell malignancies where obinutuzumab has distinct advantage over rituximab. Method of action of obinu was just explained to you. How ADCC is relevant to obinutuzumab while rituximab works only through CDC. And that's comparison of type 1 versus type 2 monoclonal antibody, which we all know. Next question is, how do clonal evolution and the emergence of resistance mutations, BTK or BCL2, differ when Zanu is given as a continuous monotherapy versus Zanu is given as a fixed duration combination? Anyone?
Yes, sir. So when Zanubrutinib is given as a continuous prolonged treatment, there is selection pressure, and the subclones or small clones which are there keep on expanding in the background of the treatment, and there is also development of some resistance to the BTK. While when we are giving the fixed dose combination treatment, even the minor clones are cleared very fast, and there are less chances of development of resistance. So that is the basic concept behind continuous versus fixed duration treatment.
Excellent. Anybody else wants to add anything? So continuous therapy has its own drawback, and the combination therapy has this one particular advantage, which was just discussed by Dr. Verma. The next question is, how does the clinical outcome of a triplet like Zanu plus Ven plus Obinu compare to a doublet for achieving what probably we don't do, but achieving undetectable MRD? Anyone?
So I'll take this, sir. So as per the data, though, definitely there's no doubt that the triplet therapy will achieve exceptionally deep responses, that is MRD negative responses. The addition of obinutuzumab, as just Dr. Arjit was talking, obinutuzumab is definitely superior to rituximab in the context of CLL. So it definitely has advantages, and it facilitates a deeper and also more likely durable remissions. Having said that, in the context of CLL, more likely we are discussing always about elderly subset of patients, so who come with definite comorbidities. And we have just seen data with the Sequoia trial in the arm C and arm D, where the progression-free survival at 3 years is 89%, and in the high-risk subset at 5 years is 72%. So in such individuals, do we really need a triplet therapy is again a question which needs to be answered. Maybe we might do away with doublet also. Is there only additional toxicity or just the responses? That question still needs to be answered.
Excellent.
So here I would like to add another thing, that for Zanubrutinib and venetoclax doublet combination, there is very convincing evidence that there is good amount of undetectable MRD over a period of time. The added advantage of obinutuzumab is achieving the depth of response and this undetectable MRD more quicker. So that gives us an increase in maybe the treatment-free remission or a more durable disease-free remission.
Right.
Again, sir, actually it depends upon the compartment where actually each and every drug is working. Suppose actually we are giving BTK inhibitor, it mobilizes the CLL cells from the lymph nodal cells to the peripheral circulation, and venetoclax works much more better in the peripheral circulation, and obinutuzumab again, it works in the intravascular compartment as well as in the lymph nodal compartment also. So it takes care holistically in a comprehensive manner as far as the disease is concerned, the triplet.
Absolutely. Very well said. So no doubt that triplet will probably clean up everything, lymph nodes, marrow, blood. So efficacy-wise, it is going to be superior. This is an article appeared in, it's not from EHA, but this just appeared in Blood Advances 3 days ago. It's 30th of June article. And look at this, that by the time you are on cycle 9, you achieve 76% of undetectable MRD. And in these studies, in the peripheral blood, 96%, and in bone marrow, 92% of MRD, undetectable MRD. Such achievements are not possible with doublets. So if one thinks of a sort of operational cure for your patients of CLL, then probably this is the way to go. Toxicity has to be taken care of. One has to be very careful that the patients are vaccinated. They are receiving prophylactic antimicrobials, and they're very, very educated to report to you when infections occur. We move to the part, and this is about head-to-head safety profile of Zanu versus Acala versus Ibru. In the early part of our discussion this evening, we mentioned that Ibru is least effective, most toxic. Acala is equally effective to Ibru, but is safer. And Zanu not only has better response, but more safety. So it achieves both. Now, the question is, what structural and pharmacodynamic differences explain the lower rate of off-target cardiotoxicity with Zanu compared to the earlier BTK? We all know that Zanu is the least cardiotoxic of the 3 BTKI. So what are the structural and the pharmacodynamic differences?
Sir, can I take this question, sir?
Yes,
Good evening, sir. Yeah, sure. So I think this is primarily explained by the how Zanubrutinib acts, its mechanism of action itself. It has got very selective BTK kinase inhibition, whereas ibrutinib is like kind of non-selective, is the first generation one. It does effect have on other kinases as well, which is the reason why there is so much of toxicity. So I think even not in Alpine, the Aspine trial where Zanubrutinib has been compared with ibrutinib in Waldenstrom also, the cardiac toxicity was much higher in ibrutinib compared to Zanubrutinib. As compared to acalabrutinib, currently I'm not very sure like whether we have data to suggest that cardiovascular profile is better in zanubrutinib compared to acalabrutinib. I think it is almost like not very different. But otherwise, I think when compared to ibrutinib, zanubrutinib does like score very well. And especially, I think we discussed in the earlier sessions like how it plateaus off after a few months. The toxicity doesn't go on increasing when compared to ibrutinib, but it does increase, especially the cardiovascular toxicity.
Thank you, Dr. Manisha. Anybody else?
As Monisha highlighted that there is probably very little difference about the selectivity, kinase selectivity of acalabrutinib versus zanubrutinib, but still acalabrutinib when used over a long period of time have cumulative cardiotoxicities, which might be lesser than ibrutinib, but still it is. But zanubrutinib has shown that the side effects are mainly upfront, and the cumulative toxicities over long-term use is very minimal. So I think that's where it is superior to acalabrutinib.
Very well said. Yes. Others? Okay. So Zanu has been specifically engineered in such a way that it's a highly selective covalent BTK inhibitor. It has got minimal off-target inhibition of alternative kinases like TEC, EGFR, HER4, and JAK3. Ibrutinib's off-target inhibition of TEC and SRC family kinases in the cardiomyocytes disrupts the critical cardiac PI3K AKT survival signaling, which drives the atrial fibrillation, ventricular arrhythmias, and hypertension. Zanu's structural precision significantly limits all these cardiovascular adverse effects. This is the kinase selectivity of Zanu versus Ibru. You can see over here versus Ibru. The bigger the circle, higher is the inhibition, and you can see how widely it is in Ibru versus Zanu. This is Acala versus Ibru versus Zanu. Once again, the percentage inhibition as the size of the circles. If you look at comparative analysis of Zanu versus Ibru in the Alpine study, as you can see, this is Ibru, that is Zanu with respect to hypertension. Atrial fibrillation, huge difference, hardly anything with Zanu, so much with Ibru. Non-cardiovascular, again, infections with Ibru versus Zanu, and other things like neutropenia, hemorrhage, thrombocytopenia, anemia, etc. Now, acalabrutinib, the problem of headache. Acalabrutinib frequently associated with early onset treatment-related headache. This headache can impact the daily quality of life and affects early compliance. Zanu does not share this specific off-target vascular effect. The headache with Zanu is 0 versus 35% with Acala. Overcoming the gastric pH limitation. Now, Zanu absorption is unaffected by the gastric acidity. It can be safely co-administered with PPI as well as H2 blockers. Eliminates the risk of decreased drug efficacy caused by common acid-reducing therapies, while Acala has a huge disadvantage from this angle. Dose flexibility. Now, Zanu can be given once a day, 320 mg, or twice a day, 160 mg, as against which Acala has to be given 100 twice a day. Otherwise, it does not reach the saturation in the plasma and in the tissues. This is the clinical matrix comparing Zanu with Acala. So if you look at the proven superior progression-free survival, phase 3 head-to-head, in Zanu, we have the comparison with Alpine in the Alpine study with a hazard ratio of 0.68 and the p-value of 0.002. As far as the acalabrutinib is concerned, it only gives us the data that it is in Elevate RR study that it is non-inferior to ibrutinib. So efficacy-wise, Acala is equal to ibrutinib, while Zanu is superior. Progression-free survival advantage in the high-risk cases, once again, in Elevate RR trial, as far as the Acala is concerned, the curves are overlapping, while if you see the Alpine study, it is superior to the Ibru. So though there is no head-to-head data with Acala, Acala being equal in its efficacy to Ibru and Zanu being superior to Ibru indirectly tells you that Zanu is superior to Acala in its efficacy. Frontline hazard ratio versus chemo, we have in Secure trial hazard ratio of 0.09. This has never been evaluated in Acala. 100% tissue occupancy is yes for Zanu. It is extremely variable with Acala. Freedom from PPI interaction we just spoke about. It is totally free from this interaction in Zanu, while significantly affects if you take it with the PPI or H2 receptor blockade, as a result of which the Acala blood levels could be significantly low. So takeaway from this comparative chart is Zanu gives you a highly comprehensive performance profile across all efficacy and the practical metrics. Move to the part 4, comparative clinical efficacy and practice-changing evidence. And the question is based on the pivotal Alpine trial and the long-term extension through 2026. What is the definitive progression-free survival advantage of Zanu versus Ibru in relapsed refractory CLL patients? Anybody?
Yes, sir.
Can I take this?
Please go ahead.
Yeah. So if I have to shorten it up, there are three main PFS advantage. One is across all patient groups, there was around 32% reduction in disease progression or death. Among this group, if we look at the specific group which has a T53 mutation, there was almost a 50% reduction in disease progression and death. And this has been attributed, and by this study, it has been proven that it is because of the superior efficacy of the drug and also because of the better tolerability and also decreased treatment discontinuation during the entire period of treatment.
Beautifully said. Lovely. Anybody else wants to add anything?
Yes, sir. So this long-term sustained benefit, we can see in this study that at the end of at the median follow-up of 42 months, the PFS was around 65% with Zanubrutinib compared to 54% with Ibrutinib. So that shows a great difference in PFS over a period of time.
Absolutely. So we just look at the conclusion because I agree the rest of the thing is not so clear in this picture. Zanu demonstrated sustained progression-free survival benefit over Ibru, which keeps deepening over the time. With longer follow-up, Zanu continued to show a more favorable cardiac safety tolerability profile compared to Ibru with no new safety signals. Next question is, how do indirect comparative efficacy data such as MAC analysis presented at EHA 2026 positions the frontline Zanu monotherapy? This is very, very important discussion. Frontline Zanu monotherapy against the recently approved, wonderfully extensively talked about Acala venetoclax doublet regimen, which just got US FDA approval a few days ago. Anybody?
Sir, Dr. Payne, so can I take this, sir?
Yes.
So, sir, with this matched independent assessment analysis, so we have not compared these two trials upfront. So there is indirect comparison of the Sequoia trial and Amplify trial. So this Amplify trial, we give this BTK inhibitor acalabrutinib venetoclax combination, and Sequoia trial this Zanubrutinib. So Zanubrutinib monotherapy has shown superior progression-free survival around 89% as compared to doublet acalabrutinib venetoclax around 78%. So better PFS benefit with this monotherapy, which leads to more durable tonal suppression as compared to the fixed duration with acalabrutinib venetoclax. So it is better in as compared to the PFS benefit with monotherapies with Zanubrutinib as compared to doublet with acalabrutinib and venetoclax.
That's right. So this is the publication, Blood Advance, indirect comparison of Zanu versus Acala plus venetoclax in treatment-naive CLL patients. And as Upendra just now mentioned, 78.9% versus 89.2%, 2%. This is the 3-year progression-free survival comparison. You can see various curves. Conclusion is the Zanu is effective across the patients, whatever type, low risk, high risk, including those which might be considered as more intensive fixed duration regimen. So Zanu demonstrated significantly longer PFS versus Acala plus venetoclax, hazard ratio 0.45, p-value 0.01 or 0.019 in treatment-naive fit patient of CLL. The robustness of these results was supported by matching adjusted indirect comparative analysis.
But again, actually cross-trial comparisons, all of us know actually doublets, they have actually better MRD eradication as compared to actually single agents BTK inhibitors. And BTK inhibitors, while we are giving, as far as CLL is concerned, we are not bothering about MRD. So again, in these cross-trial comparisons, we need to see actually how this venetoclax with acalabrutinib in Amplify trial has affected the MRD status, and again in Zanubrutinib in the Sequoia trial, so that it has been actually translated to a better PFS in a detailed way.
So can I have one question to you, Dr. Payne, sir?
Yeah.
So which arm you prefer, Zanubrutinib monotherapy or acalabrutinib with venetoclax? So one is a fixed duration and one is a long-term continuous therapy. So which is your preference?
So it was just discussed an hour ago, quite extensively by Professor.
Yes, sir.
Patient's preference is one of the top requirement, whether he prefers a continuous therapy versus a fixed duration therapy. The side effect profile related to the patient's organ function is another important aspect with which you go. One huge thing that has come up about the fixed duration therapy, and it's not necessarily it has to be Acala with venetoclax. It can be Zeno with venetoclax, the arm D of SECURE trial. So when you give a fixed duration therapy and you have a huge gap of 3 to 6 years of no therapy, you still can use the same protocol again when the patient relapses. It's not that you have to go to an alternative protocol. So slowly and steadily, I think the world is moving towards a combination therapy, probably the best of the BTKI like Zeno, the best of the BCL2, which the drug sonorotoclax, which will come at the moment, venetoclax. You saw, if you're not there, Professor showed us the curve of showing the second generation BCL2 inhibitor with Zano straight line for 6 years.
Yes, I was there. Best is we give Zanubrutinib with the venetoclax for more MRD and more better PFS and fixed duration therapy.
Absolutely, I fully agree with you.
Thank you.
The next question is, what about the real world evidence that was highlighted in EHA 26 regarding overall survival difference between Zeno and Acala in treatment naive patients? Anybody?
So what EHA 2026 did was, apart from giving us the long-term trial data of CLL patients, it opened up a Pandora box of cross-trial comparisons. But what good it also has done is showing us the real-world evidence. So real-world evidence of over more than 1,500 patients is something which is very interesting, though it is a retrospective data, sir. But it is very interesting that what happened in the trial has been exactly replicated in the real world as well across academic centers and communities both. So that is very interesting. The overall survival is definitely better with Zanubrutinib. Time to the next treatment is better with Zanubrutinib, and the same tolerability has been maintained, not just the efficacy. So that is what the good thing that happened with the real world evidence presented at EHA.
Absolutely. So this was very interesting, as was pointed out. Over 1,600 patients across community and academic practices demonstrated an adjusted survival advantage favoring Zeno over Acala when utilized as the frontline monotherapy with HR for overall survival of 0.75 and p-value of less than 0.001. Zeno also extended the time to next treatment, indicating more durable real-world disease control. So there are various ways of knowing that Zeno is not only safer, it is also more effective, and not only against IBRU, but also against Acala. So this is the real-world treatment and survival outcome for Zeno and Acala monotherapy amongst treatment-naive patients of CLL in the United States. And this is real-world comparative analysis of treatment discontinuation with covalent BTKI inhibitors in the first-line CLL. The next question is, what is the clinical and economic significance of the number needed to treat analysis comparing Zanu with Acala in relapse setting? Anybody? So this was the indication of the health economic model. 10 patients needed to be treated with Zeno instead of Acala to avoid one progression. 15 patients need to be treated with Zeno instead of Acala to avoid one death. So the health economic model indicated that Zeno requires NNT of 10 to avoid one disease progression, NNT of 15 to avoid one death compared to Acala. This clinical efficacy translates into direct cost saving exceeding $11,000 per patient in modeled healthcare resources, demonstrating that Zenu provided both superior clinical durability and statistical economic value, particularly in the high-risk cohorts. Move on to the part 5, managing special clinical situation and comorbidities. So based on EHA 26 data, for the elderly people above the age of 75, virtually half of the patients of CLL are very elderly, with a history of paroxysmal atrial fibrillation and treatment-naive CLL, how should a clinical hematologist select or manage the frontline regimen?
Yes, sir.
Sir,
So
in this case, sir, please take up.
yeah, so we all know that the cardiovascular risk factors are the most important side effect of using BTK inhibitors, and those patients who do not have cardiovascular risk factors, they are, we primarily based on the availability and affordability, we can use any BTKI. But we prefer acalabrutinib, and now with availability of zanubrutinib, probably the data is best available for minimum side effect profile regarding cardiovascular. But if the patient has already underlying low or intermediate cardiovascular risk factors like persistent or AF and hypertension and history of myocardial infarction, so in that situation, second generation BTK inhibitor should be preferred. And if the patient has severe cardiovascular involvement like congestive heart failure with EF less than 30 or uncontrolled hypertension, family history of sudden death, probably that is the group where none of the BTK inhibitors would be used.
So excellent. I think this has been beautifully summarized here. Ibru-based regimen is contraindicated due to high cardiovascular risk profile, which persists even with short-term exposure in patients over 70, and was pointed out by Professor that Ibru is obsolete because of this problem. The clinician should choose between continuous next-generation BTKI monotherapy, that is Zanu, or Acala versus fixed duration regimen, which can be when with Obino. If continuous BTKI is selected, Zanu is preferred because of the lowest rate of de novo atrial fibrillation. Baseline anticoagulation must be carefully reviewed, prioritizing non-warfarin alternatives if concurrent anticoagulation has to be done. How should a clinician manage a patient who develops recurrent grade 2 to 3 neutropenia while on a fixed duration Zanu with Ven combination without compromising the depth of MRD clearance? So you don't want to compromise achievement of MRD, but still you want to manage the grade 2-3 neutropenia. So what are the guidelines?
Sir, can I take up this question?
Yes.
Yeah, sure. So I think now the combination, mostly I think venetoclax is the reason. So currently with using venetoclax in a lot of AML patients, we are kind of well versed in treating toxicities, especially the venetoclax, how to dose interruption, support with GCSF. So I think thankfully in CLL patients, it is not as common in AML where azacitidine combination is also contributing to the lot of cytopenias. So in these patients, I think brief treatment interruptions with the GCSF support, we should be able to give the therapy as much as possible continuously. So at least for a year or 2 years, it should not be a problem, is what I believe.
Right. So management should rely on short-term GCSF support, strategic temporary dose interruptions, rather than permanent dose reduction, especially during the critical early cycles of venetoclax escalation. Because achieving a deep undetectable MRD state is the primary driver of the long-term progression-free survival in a fixed duration regimen, maintaining the target dose intensity of both Zanu and Ven will ensure that you have the maximum clonal eradication. Permanent dose modification should be reserved only for those patients who have persistent toxicity that rescues despite optimal growth factor. So this should be a small group where there is no choice for you. Otherwise, your goal will be to have the proper intensity of the drug with interruptions or using GCSF liberally. We come to the last 2 episodes. This is part 6. This is few select abstracts from EHA 2026. CLL is a disease of elderly, with 35% of patients coming first time above the age of 80, at least in US. So what is the efficacy and tolerability of Zanu monotherapy in a newly diagnosed CLL in this age group? So what was shown over here is Sequoia included one of the largest uniformly treated population of treatment-naive CLL patients above the age of 80, with the longest follow-up reported in this particular subgroup. In this particular subgroup, which was enriched with high-risk genomic feature like deletion 17p and TP53 mutation, it demonstrated durable clinical benefit with high progression-free survival rates of 72 at 72 months. The tolerability profile observed in this subgroup was consistent with expectation for a very elderly population and aligned with the established safety profile of Zenu. Rates of discontinuation due to adverse effects were low during the first 3 years. Atrial fibrillation flutter events occurred infrequently and were consistent with the general population for age-matched atrial fibrillation risk. I think this is a lot of important statement. These findings support Zenu as the effective treatment option for treatment-naive CLL across age groups, including very elderly. In other words, if you have very elderly people with the lowest risk of cardiac toxicity, Zenu will be the preferred BTKI. And this is a long-term follow-up of safety and efficacy of Zenu in elderly above the age of 80, including those with deletion 17p and extension subgroup analysis from the Sequoia trial, which I just narrated in the first 2 slides. Can Zenu be safely given to patients who have discontinued Ibru or Acala due to adverse effects? In other words, if you have side effects due to Ibru or Acala, including Acala, which made you stop those drugs, can you use Zenu now? Indicating, is Zenu safer? And will the recurrence of adverse effects will be not there or much less, is the question.
So, sir, can I take this?
Yeah, please.
Yeah, this trial has shown that those patients who are intolerant to ibrutinib, around 60% of these patients, they will not have those side effects with zanubrutinib. Around 71% of these patients will not have side effects with those side effects with the acalabrutinib. So with acalabrutinib and ibrutinib, around 60 to 70% of these patients will not have those side effects. The repetition of those side effects is with the zanubrutinib. And if these side effects are there, then those side effects will not be severe, not grade 3, 4 side effects will be there. So it's very much tolerable, and those patients, for majority of these patients, the side effects will not recur.
So excellent, very well said. When you have resistance to Acala, using Zanu may not be the good choice. But when you have to stop Acala due to adverse effects, there is a very, very large percentage of patients who will not get the recurrence of side effect because the side effect profile of Zanu is favorable. So you can go to Zanu before jumping to a BCL2 inhibitor is the summary of all these slides and what was brought out by just now. So Zanu may be an alternative treatment option for patients with CLL who are intolerant to either Ibru or Acala, is the conclusion. And real-world Zanu treatment patient in CLL amongst US community patients who have received prior Acala, again showing that the recurrence of intolerance is only in 20-30% of patients. After Zanu monotherapy in newly diagnosed CLL, do we know the time to the second PFS event after the subsequent therapy? That means if you use Zanu upfront, and if after a few years you have to use the subsequent therapy, will the second PFS be good enough? Versus, say, for example, use venetoclax upfront and Zanu in the next line. That is the question. Anybody?
Yes, sir. Definitely. Actually, after giving Zanubrutinib, we have option of other agents like venetoclax and anti-CD20 monoclonal antibody like obinutuzumab based salvage regimens also that can be very much effective, and we can give it. And again, we don't have the option of actually non-covalent BTK inhibitors like pirtobrutinib and BTK degraders, as Professor has told. Those are also other options by which we can actually salvage the patient and have a good durable PFS2 also after Zanubrutinib.
Absolutely. So using Zanu upfront does not compromise the outcome of alternative treatment that you use subsequently. So subsequent therapies and time to the second progression-free survival event in CLL previously treated with Zanu versus bendamustine rituximab. And this also difficult to read, but that is what we have just mentioned. Is there any data regarding improvement in impaired health-related quality of life scores after Zenu versus earlier BTKI? health-related quality of life is extremely important. So medical support, mental health, lifestyle adjustment, social support, future planning, all are important. And there were these presentations in EHA, longitudinal analysis of patient of CLL with impaired health-related quality of life score at baseline versus treatment with Zanu versus Ibru, continuously showing that Zanu was much superior to Ibru. And are there any associations between ECOG performance status and patient-oriented outcome in relapsed refractory CLL subjects? Again, there was a demonstration that association between ECOG performance status and patient-reported outcome in relapsed refractory CLL patient post-hoc analysis from the Alpine study was in favor of Zanu. We come to the last part. I'm going to show you some case profiles, which will make it very, very objective and practical. Profile 1, a high-risk genomic patient. The hook. Let's look at our first patient, a 64-year-old male with progressive lymphadenopathy, profound fatigue, and worsening cytopenia. His workup shows ultra-high-risk profile of deletion 17p and TP53 mutated CLL. The problem, historically, while treating these high-risk patients, the mindset has been any response is good response. But remember, a partial response in the patient with TP53 mutation is a ticking clock. It leaves an unstable, highly mutated clone active, paving the way for early clonal evolution, rapid resistance, and abbreviated progression-free survival. The solution is we cannot settle for a shallow response. We need the deepest possible clonal clearance to disrupt this trajectory. That is what exactly Zanu does. It alters the clinical course. In head-to-head data, Zanu delivered a 3-fold higher CRR compared to older therapies. This isn't just a statistical merit. It represents a profound biological clearance of the malignant clone. The pivot, when we look at the long-term Alpine data, this deepest clearance translates directly into statistically significant PFS advantage, specifically in the ultra-high-risk deletion 17p and TP53 subgroup. For a standard patient, a partial response might keep the disease at bay. But for the high-risk patient, Zanu gives you the absolute best chance to push back the clonal evolution and extended survival. Profile 2.
Sir, can I ask a question, please?
Yeah, please.
Sir, this is a standard guideline that a patient who have deletion 17p should receive continuous BTK inhibitor, and fixed duration therapy has shown better results in non-deletion 17p. But we discussed moments before that a shorter and combination therapy, fixed duration therapy, will not allow clonal evolutions to happen. So isn't this very contradictory that we are actually using a continuous BTK inhibitor in the most high-risk possible patients?
Right. So I would put it this way, that the standard thinking was that a short duration therapy for an ultra-high-risk patient, even if it is combination, will result into early relapses. You will get a PFS of a very short period. Versus if you just keep giving a monotherapy with one of the BTKI, you will not achieve the undetectable MRD, but patient will remain under clinical control for years. The thinking is changing. You are absolutely right. Because once you use a combination like Zanu with venetoclax or this new molecule sonrotoclax, you get such deep responses that you will get progression-free survival of 3 to 6 years, which will allow you to use this protocol again. You can once again use these drugs. So you're not really compromising the outcome of the patient with high risk. So what was said yesterday, continuous therapy, tomorrow could change because you've got such powerful BTKI and powerful BCL2. And I think it's going to happen very soon. It will get into the standard line of the standard guidelines, which is not there at the moment. So it's not really contradictory. It is evolution of the line of thinking and data generation. I'll put it this way.
Thank you.
Now, profile 2 is a polypharmacy elderly patient. The hook. Let's consider a patient type that we see every week. A 76-year-old female, treatment-naive CLL, has osteoarthritis and a long history of GERD. The problem, to manage her reflux, she takes omeprazole daily and uses over-the-counter antacids. If you choose ACALA for this patient, you are introducing an immediate silent clinical risk. ACALA strictly requires an acidic gastric environment for its absorption. Co-administration with PPI is contraindicated because it severely reduces drug exposure, risking subtherapeutic target coverage. As a result of which, there will be early disease progression. Solution: we cannot realistically police an elderly patient to take over-the-counter antacids. The Zenu, you don't have to bother about it. Zenu's absorption is entirely independent of the gastric pH. Whether she takes PPI, whether she takes histamine blocker, whether she takes TUMS, her drug exposure remains 100% stable and predictable. The pivot: in the real world, compliance is messy. Patient will take antacids regardless of your warning, leading to silent underdosing of ACALA. Zenu removes that variable totally, ensuring consistent maximum target occupancy without forcing the patient to choose between managing her GERD versus CLL. Last profile, the cardiovascular risk factor. The hook: let's address the elephant in the room. Cardiovascular safety. Consider a 71-year-old male with controlled essential hypertension on lisinopril and a mild stable coronary artery disease. The problem: while considering Zanu, the panel often looks at roughly 15% rate of grade 3 or higher hypertension and hesitates, worried it will worsen his cardiovascular risk. But actually, we need to look closer at what the cardiac signal than the patient's outcome. The solution is there is a fundamental difference between modifiable risk factor versus a catastrophic cardiac event. Hypertension is highly modifiable. If this patient's blood pressure spikes, we can easily titrate his lisinopril, add a calcium channel blocker, etc. What we cannot easily manage is this patient getting a sudden atrial fibrillation or flutter and then getting an embolic stroke. Frequently, this forces a permanent treatment discontinuation of the first generation TKI. The pivot: Zanu maintains a significantly lower risk of atrial fibrillation and flutter. As clinicians, we must ask ourselves, would we rather manage a predictable, treatable blood pressure reading or a dangerous arrhythmia which forces us off the primary oncology treatment? Zanu gives us a safer and highly manageable cardiovascular profile. Now, this is safety, tolerability, and the dosing profile, and I think the most important slide of the day. If you look at the atrial fibrillation and flutter, Zanu 5%, ACALA 9%, Ibru 13%. Zanu delivers the lowest cardiac arrhythmia rate. And mind you, this has been found to be equal to an age-matched control group. Unique class toxicity: Zanu has none. ACALA causes headache in 30%. Ibru causes very high risk of hypertension and bleeding. ACALA causes unique early onset headache. Zanu avoids this distinct tolerability issue entirely. Gastric pH and the PPI restriction, we have talked extensively. BTK target occupancy, which is something which should never be forgotten from the angle of efficacy, 100% continuous occupancy by Zanu, extremely variable and intermittent by the other two. So Zanu provides complete sustained 24-hour target coverage in both the blood and dense lymph nodes, even when you give it once a day and not twice a day. Head-to-head and indirect efficacy comparisons: progression-free survival, Zanu superior in alpine as against Ibru. ACALA is just non-inferior. So indirectly, as I mentioned, Zanu is superior to both Ibru and ACALA because ACALA is not superior to Ibru. Overall response rate 86, 81, 75. 17p deletion, TP53, 47% risk reduction. Here it is comparable to Ibru and not superior. Complete response rate higher, is lower and lower. So in closing, The data presented today leaves us with a very clear defining judgment. When the science presents us with a tool that delivers deeper clonal clearance, fewer treatment-limited toxicities, can we settle for lesser? We have looked at 3 distinct everyday patient profiles just now. For the high-risk genomic patient, Zenu isn't just an option, it's the critical shield against evolution of a clone which is resistant and which happens rapidly. For elderly polypharmacy patient, it provides an absolute pharmacological certainty. And for the cardiovascular risk, it offers a manageable path forward rather than a catastrophic cardiac event. We can no longer treat CLL with the mindset of the past decade. The evidence shows that Zeno maximizes time on therapy and delivers statistically superior progression-free survival. I urge our colleagues to make Zeno our standard so that we can give our patients absolutely highest probability of long-term uninterrupted remission. And then whether it is Zeno monotherapy or it is Zeno venetoclax doublet or it is Zeno venetoclax or even tomorrow sonrotoclax with and without obinutuzumab. So concluding, Zeno redefines the standard of care for CLL. There is a definite case for Zeno superiority, both in upfront and the relapse setting. It delivers structurally superior pharmacokinetic, leading to deeper clinical response and uncompromised safety. It delivers significantly higher plasma exposure than ACALA, ensuring continuous therapeutic level. Its minimum binding to the TAC, EGFR, ITK, JAK3 relative to the historical competitors establishes the fundamental reason for its clean safety profile. Well, Zenu redefines the standard of care in CLL. There is a definite case for its superiority across both settings. Because of its pharmacokinetic, it leads to the deeper clinical response and uncompromised safety. It delivers higher plasma exposure than ACALA, ensuring continuous efficacy. I think most of it was a repeat. The sentence was to be read was the down at the bottom. The first generation agents, ibrutinib, proved the pathway. The second generation agent sought to fix the safety. Zenu represented the third wave, optimizing both maximum efficacy and the safety, and that is what we have been talking all along. And lastly, Zenu is not just another next generation BTK inhibitor, it is the BTK inhibitor. Well, thank you so much for this lovely discussion. If there are any questions, any doubts, we can discuss them now for next 5 minutes.
Sir, will we have Pertubrutinib anytime in India? I mean,
what will we not have in India? So we will have it in India. There's no doubt about that. But I'm very clear about not using Pertu upfront. If you use it upfront, you've wasted one modality of treatment. So as was mentioned about Professor, you must use one of the BTKI out of these 3 which we talked about as the upfront treatment. And with today's discussion, it should be Zenu, so that you can keep Pertu for the next line. If you use Pertu upfront, you lost the bus of using Zenu as the second line therapy. So you should not do that. It is, like we discuss in CML and we discuss in other diseases, you should not use the drug which compromises the use of one generation of drug totally in the next line. Like say, for example, there are papers presenting about lenalidomide being replaced by pomalidomide upfront. Now, what do you do when the patient relapses? You lost the IMID. Carfilzomib used upfront. You lost, again, one of the PI. So one has to be careful about these things. So Pertu will be available, no doubt, but should be kept for the relapse setting as far as I'm concerned.
Sir,
yeah.
So should I conclude that, what I could conclude from the meeting is that any CLL, when we have an indication to treat, the time comes when we have to treat our CLL patients, then they also be treated with a BTKI, preferably Zanubrutinib. And whenever possible, we can upgrade this monotherapy to triplet, means preferably doublet, and then if possible even triplet, adding venetoclax or the newer BCL2 whenever we get, and even the CD20 inhibitor antibody like obinutuzumab. So should it be like that, sir, that we should go, this minimum should be Zanubrutinib and we can go up to triplet unless there's some contraindication, financial or for whatever, clinical or anything?
So I'll just slightly modify what you said.
Yeah.
If the patient wants continuous therapy, Zanu monotherapy.
Yeah.
If the patient wants a fixed duration therapy, then Zanu with venetoclax doublet. If the patient is very young, robust health, absolutely no contraindication, can survive infections, has been fully vaccinated and is going to take properly the antimicrobial prophylaxis, then maybe the triplet. Especially if he has got a poor prognostic CLL like deletion 17p, etc. I will not jump to triplet in majority of my patients, and monotherapy versus doublet, I will decide based on what patient preference is. I have a slide which I didn't show. I think patient preference comes to the top, especially now that you have got such potent drugs which take care of everything. So you're not worried about deletion 17p, you're not worried about TP53, you're not worried about the complex cytogenetic, unmutated. Now what you want to do is the best BTKI, so Zanu, and at the moment the only BCL2 you have is venetoclax, but it will get totally replaced with that sonrotoclax.
Correct.
And Obinu is a difficult drug to handle, I must say. We have to be very careful. Younger patients, fit patient, okay. Elderly people, it's a difficult drug to handle.
So
Thank you, sir. Thank you.
My question to you. So, how do you see the finite therapy for high-risk CLL patients?
Oh, yeah. I mean, finite therapy is possible for the high-risk patients very, very easily because, again, BCL2, either first generation, venetoclax, or second generation, whenever it comes, together with a most potent BTKI like Zanu, upfront, give it for a year. If you want to do MRD, do it. If you don't want to do MRD, we don't have MRD availability, it's fine. Otherwise, I will be tempted to little bit guided by the MRD so that I don't overtreat anybody, I don't undertreat anybody. That will be the fixed duration therapy for a high-risk CLL in my mind. Zanu plus venetoclax in our setting.
So
the question asked, Obinu can be added for a young, very fit person.
After a year, this high-risk patient has MRD positivity for a year after.
If you've got a reliable MRD positivity test available, I would continue it for 1.5 years, 2 years, till MRD becomes negative.
Sir, I have one practical doubt actually. So while giving venetoclax at 400 milligram, we all of us use actually azoles. So in CLL, combining actually venetoclax with azoles with BTK inhibitor, say acalabrutinib or zanubrutinib. So what is the actually drug interaction point of view? Any experience?
There's a beautiful drug interaction. You can use Zanu 80 mg.
Okay, sir.
Use venetoclax 100 mg, and you can use posaconazole 300 mg. So yes, with the generics, you can decrease the cost of treatment by using Zanu only 80 mg. 80 mg of Zanu with 300 of posa is equal to 360 mg of Zanu.
Okay, sir. Okay, thank you.
Acalabrutinib for acalabrutinib with azoles.
Acalabrutinib is generic, so one doesn't bother much. You just give 100 mg twice a day.
If you are using with venetoclax, posaconazole, so acalabrutinib has to be reduced. Dose of acalabrutinib has to be reduced.
That, yes, but I'm sure you are aware that next week venetoclax generic is getting launched. Just by next Thursday, venetoclax generic by 10 companies is getting launched. So you've got generic venetoclax, you've got generic posaconazole, you've got generic acalabrutinib, and if a patient cannot afford full dose of Zanu, you can use 80 mg. I have used it, 80 mg with posaconazole for a patient who says this full dose is totally out of my financial situation. I have very significant number of patients on Zanu now. So large number of them are on full dose. It's a beautiful drug to handle because side effect profile is 0, and you're giving the most potent drug, and you're giving it for type of patient where the genetic does not matter. And you are not doing injustice because cardiac profile is the safest you can ever have. And with the data showing atrial fibrillation risk equal to an age-matched control, you are doing a very safe job.
So how many of your patients will tolerate 400 milligram of venetoclax for a year?
Half the patients. In the beginning, there's a problem. So when you go from 20, 50, 100, 200, from 200 to 400, there's a problem. So I use GCSF quite liberally. I give drug holiday also intermittently till the count comes up. My goal is that I should reach at least 300 and if possible 400. It's invariably possible after first few months. In the first few months, very often it is 300 and not 400. But as I am aiming at 15 months treatment, I want to push in the maximum so that when I stop, because I don't think the MRD that is available to me, I can trust. So I don't go with MRD because I'm not sure what I'm getting the reports. So I go with a fixed duration, 15 months, 3 months of whatever drug you're using plus 1 year of venetoclax. So there I like to push to the highest level. So the patient doesn't come back to me in 1 year and 2 years that he has relapsed. And see, majority of the patients on Zanu are patients who are VIP, affording, educated. But that's why they can afford all this. So such patients, you want to push in the maximum venetoclax with or without GCSF. And they're educated enough to report to you if infections occur.
Thank you, sir.
Okay, I think 9:40, enough. Is there anybody from company to give the vote of thanks? Yeah, Sumit, please.
Yes, sir.
I must appreciate your perseverance that you are here for 3.5 hours. Fantastic.
It was a marathon session, sir. And sir, I think Zydus venetoclax is already available in the market, so you don't have to wait till Thursday also. It is already available now, from today onward.
Today, okay. Today is the launch day. Wow.
Yes, sir. We have launched it today, and already it has been dispatched to all the cities.
Wonderful, great. Now that's a big news for both AML patients,
Yes, sir.
an MDS patient and the CLL patients. It's a huge, it was a stumbling block. And you don't know when you're using Bangladesh preparation and all that, what is the quality? So wonderful to give us quality product.
Thank you, sir.
D-Day.
Thank you, Dr. Neeraj Arora, Professor Zuzak, for delivering great talks. I think both the talks were wonderful, and it was followed by a great panel discussion, which was moderated by Dr. M.B. Agarwal. Thank you to all of you for sparing your valuable time. On behalf of Zydus, I thank Mumbai Hematology Group, and a special thank to sir for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank all the discussants and participants who have joined us for this webinar. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. Thank you so much, everybody, and have a wonderful evening.
Thank you, Mr. Sumit, for supporting our activities.
Thank you, sir.
Thank you, sir. Thank you.